Good. Ryan, I'm sorry. We'll get you a bigger bag. All right. All right, so we're going to get started here. I want to just thank everyone for coming in for this. This is our 14th annual Los Angeles Melanoma Education Symposium, and I'd like to always start by thanking everyone for showing up and remembering a time 14 years ago when we did this and no one zoomed in, and that was not a thing. I mean, they zoomed in on flights. They came from Nevada and Idaho and Iowa and Washington to hear us talk about something. And well, let me see where that went. But this year we have over 150 people who are zooming in from Nigeria and Canada and Australia. Oh yeah, oh absolutely. And so it's very wonderful. It just gives us some thought because now we have so much to talk about because we have so much to utilize. And that's only in the United States where we have such access, and access is coming around the world. So hopefully we'll get this going. I wanted to just begin by thanking you for showing up, recognizing Samantha Guild and AIM at Melanoma for the collaboration and the guidance that has made this type of meeting a success around the world. A few people, I mean, we like to think locally of LA or the States, but this is something that happens globally and at many, many academic centers with a greater power and reach to patients. That type of one-to-one with patients and advocates and everything is one of the greatest reasons why we've made the successes that we've had in melanoma. And let's not forget, for those of you who see friends with other malignancies, that the work that's being done in melanoma is the work that's guiding breakthroughs in other solid tumors. When we were presenting some of the early data with checkpoint inhibitors, it seemed like it was something that would only stay in melanoma, but now I don't even know the number of cancers, gastric, esophageal, renal, breast, that are affected by immunotherapy. And today you'll hear from the best. I will say that it will start with me, and the quality and the expertise will increase, which is great because we're going to begin by talking about where we are for initial therapies, and then go into some of the rare types of melanoma. Then we'll talk about a place where we really didn't have therapies, adjuvant and neoadjuvant, and the hopes of bringing all of that benefit to other solid tumors. You'll hear about how one of the trials that was major in melanoma is going to be upfront as one of a handful of the best presentations at the biggest meeting. We'll take a step back in quality, and Dr. Sullivan will we'll hear from Dr. Sullivan about new options, and obviously the approval of TIL therapy in melanoma only is scratching at the surface for what we can do for other tumors like cervical cancer, lung cancer, head and neck cancer. And as that quality hits an acme, you'll be introduced to one of our newest fighters on our team, Dr. Anthony Nguyen, who's joined us in the radiation oncology department, and is really this whole idea that's come not only has changed how our colleagues in medical oncology think about treating patients with all solid tumors. It's also changed how our colleagues in surgical oncology speak to each other. And Dr. Ferries is a leader in that field. And Dr. Nguyen and Dr. Shao, some of you listen to Dr. Shao speak, are again leaders in how to keep the peace between the medical oncologist, the surgical oncologist, and the radiation oncologist. And then we'll end with questions, and that and sandwiched in the middle there is where I feel that we overlooked, but now need a greater voice, and that's where AIM and Sam Guild and everyone is coming in. Survivorship. How do I deal with doing well? Yeah, okay. And we'll move from there. So we will go to the first talk. That's my talk. It's just talking about it was very hard to talk about 14 years ago where to start, and now it's equally difficult to talk about where to start because there's so many options. It's like an embarrassment, partly because we have so much, partly because we still are trying to figure out how to utilize that and find the right people and create the best therapy for them. So we'll talk about novel approaches for the initial management of advanced melanoma. I did say that I will use the timer. It is fancy. That reminds me to thank the most important person that has ensured that this meeting goes off without a hitch and without a lot of involvement here. That's Connie Doe. Connie is great. She could run this and set this up without me. And that's my greatest fear. Oh. Next year, I won't be invited back. She'll just say, you didn't do it. You didn't keep up the quality. All right. So those are, I love this conflict of interest slide because it just shows really how many people are there fighting with us, how all of the pharmaceutical companies who are working and are listening. I mean, you can take my picture out of there and put every other medical oncologist picture in there because we now have a voice and we talk face to face. Oh, I usually steal a lot of slides from Dr. Sullivan, and this is my favorite because it shows us how many agents we now have approved and where we have gone. When we started in 2010 with this meeting, we didn't have anything standard. We were talking about FDA thinking about approving this thing CTLA-4 that had a low response rate and possibly a lot of side effects. We didn't know what to do. So the talks were easy. You could just say whatever you wanted and you didn't have to know much. You could just talk about what's in clinical trial with no data. And there was this sense of tension. And now where we're here, we have just gotten more and more approved, and you'll see where it's going through these talks. When we give these talks, we try not to have slides that are too busy, but the main idea of why immunotherapy has come to the forefront is we found out how to take this T cell, the major immune cell that's hanging out in our bodies that causes inflammation and all these autoimmune diseases, and use these activating receptors, which are, you stimulate them and they cause that T cell to go into overdrive, or you block an inhibitory receptor, you take the brakes off, and you allow these cells to recognize tumors as foreign, just like they would recognize a virus as foreign. And we found that as immunotherapy, we become resistant to it, or if it works and then it stops working, or if it never works, there's this idea that we need to maybe target more of these or find out how to, when and where and how to target them to move forward. We've understood that, anti-CTLA-4, this Yervoy, ipilimumab, can work in one area and some can work in the other. So initially in the lymph nodes, and then distantly when the T cell comes to the tumor. We've had multiple studies looking at that, and now we've come to a position where we have so many options. We need to now take a step back and understand why something works so good in our young female patient and doesn't work as well in our older male patient or the other person that comes through. It was easy to do simple trials in the past because let's put X and Y together. We only had 3 things in the toolbox, but now we have to take this idea of looking at complex. So what do we now know? This was the checkmate study of ipilimumab, nivolumab, and it is the pinnacle of what you want. You want a study that takes a median survival, that's where 50% of patients have succumbed to a disease, from 6 to 8 months and turn it into 6+ years. And clearly what you see on the left is where we were before, pre-checkpoint, pre-BRAF therapy. And what we have on the right is this idea of a survival curve. These are survival curves. So it starts at 100, everyone is here in the room, and slowly, unfortunately, becomes less and less. What you'd like to see is these curves going higher and higher, like you see here. You have this, and you have this, you add something on, it goes up. And then you'd like to see this thing we call a plateau. And the plateau is really easy. It's something you learn in like 3rd grade math. It just hits and it becomes flat. And that means that you are taking people to from a concern to a long-term survivor. And we see this with immunotherapy in multiple solid tumors. Unfortunately, it's so much lower than in other solid tumors. And as we figure out why this is like this in melanoma, we can take it to other solid tumors. We've also understood that possibly higher doses of some of our drugs are helpful. I put this up all the time, but if you look to the left, the difference between lower dose of anti-CTLA-4 and a higher dose is a significantly higher toxicity. That's why we don't really give the 10 milligram dose. But in the long term, as a single agent, it is better. Now, in combination, you might not need that. But what if you could get it to get the best of both worlds? Have a Yervoy-like drug that doesn't have the same toxicity, so you can dose it higher and higher and higher. These are the questions that we're trying to answer for you. I mean, not for you, because as I look around, there's a lot of long-term survivors here, but for everyone. And also, this will be like my only adjuvant slide, but in those patients who show up with a single area of metastatic disease and then we take it off, do we really need to do something, and how can we improve it? And this shows that combination really does that. You can see that it goes higher and higher and higher as you add an anti-CTLA-4 and an anti-PD-1, as you add Yervoy to Opdivo, things like that. Well, what else have we learned? And this is something that I love to speak about, is we've learned that it's not just good enough to get people to a control of disease. It's good, but it may be better to get them so that all of the disease either goes away or it doesn't show up on a PET scan. These are progression-free survival. That means how long you control the disease based on your response. So the CR is a complete response. That means everything is in the scans are gone, or in a PET scan, it doesn't light up. Partial response is you get a major shrinkage, but not fully. And you see, as you go in time and time and time, yes, you see a plateau, but it's great to get control. It's not the most optimal. And that's the same as if you look at it for overall survival. These are a combination of anti-CTLA-4, anti-PD-1 versus each single alone. And you'll see that it's true for other combos additionally. So the next step for us for some of the early first-line patients is, look, we have controlled your disease. Everything is gone. Your PET scan is still viable, it's still lighting up, or we haven't gotten the best. How do we add things on, whether it's radiation or surgery, to get you to the place where we can move you up from, coach to a premium to first class response. We have 2 people flying out today. I'm just going to talk their language. And so as we have gotten more and more experience, we do find little nuggets, right? We take these trials and we look at 1 year, 2 year, 3 year, we continually present them, and people say, why are you continuing to present this? This is just the same thing I saw. But if you look at the tail of the curve, where on the bottom left, those are the plateaus we love. But what comes from this, and this was just presented at last year's big meeting, is that if you get to a durable benefit at 3 years, that points towards a melanoma specific survival that's over 95%, right? So these first 3 years are key. And so that's where we're going. Okay, what else? When is the big question, if you have a BRAF mutation, which a lot of people here do, and a lot of my patients do, and we never utilize it, there's a targeting of drugs that target that mutation. But should you start with this or the targeted agents or the immunotherapy? Well, we've looked at that now and found that these are response and overall survival. We found that the blue line, where you start with immunotherapy, is the most important one. And this is a paradigm that holds for melanoma and may not hold for other solid tumors. But as we get better immunotherapy, these will become questions for other solid tumors. It's also a question, if you see initially that overall survival is orange, and then the blue starts to tick up, what do we do for those people? How do we identify those people? What are characteristics for them where we can say, all right, you're not an immunotherapy person? And so that's coming into our paradigm. We never knew that until we did these studies. Additionally, if you look at this again shows you that even with targeted therapies, we need to get deeper, better, bigger responses, right? That's a big LA thing. Bigger, bolder is important, and it's important here. A good friend of ours, Paulo Cierto, looked to try and figure out how to help these people, on the right, where the orange is targeted therapy, helped that population better. And so he said, well, let's not just continue the targeted therapy. Let's start with a little burst, control disease, and go to the immunotherapy. And he did that and basically showed that in those patients who have aggressive growth, they need those targeted therapies because they work so much faster, but you don't need to keep them on it until the tumor becomes resistant. You need to bring in immunotherapy earlier. So these paradigms are important. How about toxicity? When we talk about combination, where toxicity gets greater, and we talk about side effects like colitis and nobody likes to have that, or the rash, and nobody likes to have that, or the diabetes. And so we're looking at novel combinations. This was a combination where we just flipped the dosage in a certain population and showed that the side effects profiles is less. So we're looking at how to manipulate therapies, not only to get the side effect profile to be less, but also maybe add something that can increase our responses and benefit. A lot of you have heard about the LAG-3 PD-1 combination, and this has come on. It's now given us another combination that looks great. We're not quite clear how it works in certain subpopulations of the most aggressive. I see a patient saying, like, why didn't I get that? Well, we still don't know how it works in patients with initial brain mets, where the other combination has been around longer, or bigger disease, or BRAF disease. And this was the same way, looking at that combination of LAG-3 PD-1, so the relatlimab nivolumab versus the PD-1 alone. We showed that progression-free survival is better. Overall survival, not statistically better, but some indication that it's better. But what I like about this here is that it proves the point of immunotherapy. And that's if you start looking at 3 years, you're now seeing that plateau we talked about. And it's an indicator to me of a therapy that has promise, that works, that we can look at. And again, it became like, how can I say it? It became like Coke versus Pepsi, Coke versus Pepsi, Coke versus Pepsi. And as you'll see, we found a way to sort of say, let's mix it all together and get a better drink. Here is now early data from that trial showing that when you combine, that you get better control of patients in the everywhere. The incidence of brain metastases, which is something we try and avoid, is less in people who don't have brain metastases, and see combination. So this is another reason we're looking to move to combination. Again, now we are now building an infrastructure to say that, again, getting a complete response is better. Is it better because those people had some better characteristics, or is it better because same people with same characteristics, the one that gets a CR, a complete response, does well? Well, it just, for me, is let's get them to complete response. Let's look at trials that add things on for a person who's had a good response to get them to a deeper, better response. And some of those trials are coming. We have one opening with something that takes care of regulatory T cells. But we're also understanding that the tissue itself is helpful for us. Looking at how much PD-1 is expressed. These are things that you hear about. You have a low PD-1, well, low PD-L1. What does that mean? Really is indicating to us that you may need a combination rather than a single agent, because some of these combinations outside of the United States are only approved for people who have a low PD-L1, where a single agent may not be as great. But also, when you look at this is not standard, but it came from this trial. If you had a low LAG3 expression on your cells, you did not do as well in progression. The benefit was equally strong, but if you had a low level, you are someone who is going to progress very rapidly, regardless of what you got. And through some of the work that Dr. Memi is doing, we're going back to look and see if we could figure out if those patients who had low lag expression did this poorly or did much, much better if they got like an anti-CTLA-4 regimen. So possibly that's important and possibly not, because I don't remember where my slides are, but we're trying to look at these head-to-head. You don't need to write any of this down. I was one of those students, I had to write everything down, and the slide would move too fast. But the whole thing about it is that we're now looking at subgroups, trying to understand who does better, because we could never go and do another big, huge trial, 3 arms, head-to-head. And we're looking at things like hazard ratios. How did you do on this trial compared to just a single agent? How did you do on that trial compared to single agent? And then we can sort of do a transitive look at it. Okay, what else is coming on? We're now through this idea that we need to move away from these checkpoint inhibitors. Yeah, it's great to make a good it's great to make a good blouse, but you can't just build a company on just making blouses. Let's make some other things and build our our immunological brand on other therapies. And how can they help? For a long time, we have known that there are hot tumors and cold tumors, and it's really hard to come to an understanding of how to explain that to patients if you start to delve into all of the data. It's just that you don't have enough T cells in your tumor. Those T cells that you're trying to agitate with your therapy are not there. So even if you can agitate them, it's not enough. So some of these newer therapies we're looking at are, are important. But even as we move from there, we're also trying to improve some of the lag therapy, some of the checkpoints. And this is one where we've seen a higher response rate with a lag inhibitor and a PD-1, and it's going in randomized 3 trials, but possibly it's because we were giving higher doses or more frequent. We don't need that. Sorry. So how about predictors of poor T cell response? How do we agitate those T cells? Well, predictors of toxicity, and interleukin-6 in the serum has been important there. Interleukin-6 is a thing that caused COVID lung. Okay, it's easy to understand. It's an immune flare. It is causing off-target side effects and toxicity. And through work that same Checkmate 67 Ipi-Nivo trial did, we found out you did poorer if you had higher levels of IL-6. So associated with shorter overall survival. So how do we target that? Well, as you'll remember, there was a drug that targeted IL-6 that was used for COVID lung. We use it for patients who have a huge immunological flare. And some people decided to say, let's look at it earlier and earlier, even in first-line patients. This is a trial done at MD Anderson, where Dr. Patel worked as she transitions to a new place, but it added that drug, tocilizumab, into combinations. And what did we see? It increased immune cell infiltration, decreased the incidence of side effects, and may increase response rate. And we've done a similar trial here. And now we're looking at this trial. And this trial is a huge jump. The huge jump comes from the fact that I didn't talk about putting together CTLA-4 PD-1 and a LAG-3 inhibitor. That's been done and will be presented in less than a month at our big meeting. It may have higher response rates, and that's what we've seen. It may have higher side effects, right? As I said, if you add 1 + 1 is 2, but it's a higher side effect profile. 1 + 1 + 1 is 3. It probably has a higher side effect profile. So we decided, not me, but Dr. Weber at NYU and a trial that we're doing here and there for first-line patients, let's add everything together, everything in the toolbox, and an IL-6 inhibitor to decrease the incidence of side effects, maybe increase efficacy, and this is currently accruing. We talked about the anti-CTLA-4 drug ipilimumab, known as Yervoy, and how the 10 milligram dose had so much toxicity. The toxicity was that it was going not where the tumor was, it was going to where normal tissue was, like your colon, like your pancreas, and it was inflaming. So there's a drug that we're looking at in clinical trials. It's called conditionally active antibody. So when it gets into a acidic environment, like where the tumor is, it's active. When it goes into a non-acidic or less acidic environment, like your colon or your pancreas, it's inactive. Just basically is just on the lazy river going to when it gets to the tumor. And so that's great. What about the first line? So this is now, we've gotten to doses that are tolerable, and the doses that we're looking at in combination now, the 700 milligram dose is thought to be equivalent to the 10 milligram per kilogram dose of anti-CTLA-4. And we are not seeing the same incidence of other toxicities. We're seeing some cytokine release. And we're combining it with an anti-PD-1, that nivolumab that you guys know as Opdivo, at a 240 milligram dose, at a full dose, not a third dose that we utilize in our combination every 3 weeks. So higher dosages of both, hopefully, and this is now in a first-line trial here. So that's fine. We've only seen 2 patients with immune-related adverse events that are high grade, whereas we should have seen more. But also, what have we seen in it in the combination? We've seen great responses in other solid tumors. And our 2 people, the cervical cancer patient here is one that we treated here, had everything go away. So that's very rare to see. And we hopefully some of these, as the trial accrues more, got to run through. So it's now looking at a melanoma. What we've also seen and what prompts us to look at improving is in our trials of Now, going and doing some of these combinations after you've already seen a PD-1, we see very low response rates, very short control. So bringing it all earlier is better, possibly. Again, you can skip over that. Let's talk about vaccines, because that's so big now. You've heard about the vaccines and you want part of it. This is a vaccine that is off the shelf, that comes from a company, IO Biotech, that is a vaccine to 2 proteins found on your tumor cells. And basically, you're giving it along with the PD-1, you're priming the immune system because the T cells see that vaccine, they target the tumor, then you boost. And initially, early on, the initial small study of this in first-line patients showed something very interesting, an 80% response rate. That's one of the highest response rates. And the academics sitting in the front row here will say, well, that's a small study. It's only 30 patients or so. That's fine. But it had a 50% complete response rate. And I like that, right? We've started saying the complete response rate is great. So when you see this, you say, that's great. It was very tolerable, not a lot of side effects. It's a combination. I'd like you to do a big study, randomizing hundreds of patients and tell me how it shows. And it's been done. This is accrued and will be presented within less than a year. So we'll see how that works. Hopefully we'll find something on how to bring a vaccine in, because it is an easy thing to combine with low toxicity. Okay, now this is what I was talking about, bringing in the T cells. And these are ImmTACs, which are like a double-sided antibody here. One side brings the T cell in, the other side targets a protein on the tumor. And we've shown that this has been successful in the hardest melanoma to treat, ocular melanoma. The first drug approved was a drug that we had in phase 1, small studies, big studies, it randomized, it showed significance. But now there are other drugs like this, and this is the targets of protein PRAME. Again, PRAME is on 90% of melanomas. PRAME is also on endometrial, non-small cell, triple-negative breast, small cell lung cancer. So there is a lot of tumors that this can help. This is how it really works. It brings the T cell next to the cancer cell, sort of like a matchmaker. And then they get together, they fight. The T cell wins and destroys the cancer cell and moves on. And we have seen this in the trial, that once you give it, it causes the lymphocytes, your T cells in your blood, to fall down. Where are they going? They're being trafficked into the tumor. You can see pre-treatment, not a lot of purple, and then post-treatment, as we biopsy patients, a lot of purple. And it is showing great responses. We'll be talking about that at our big meeting in less than a month. And it's already being looked at in a first-line trial in the randomized fashion, right? So people will be getting a PD-1 inhibitor plus that ImmTAC that's bifunctional antibody versus a standard therapy. And this is hundreds of patients, 650 patients. So for those of you out there zooming in, I think the point to take away from it, even if you have done well, is to talk to those patients who come to you and say, what should I do? Where should I go? Find a place that has expertise. See if you can benefit from some of these trials. See if you can benefit from the expertise, and allow that oncologist to work with your local oncologist to make plans. And to make plans doesn't mean listen to the talk that you're hearing now, but to listen to the second line talk, listen to the TIL talk, and try and bring that into your treatment plan. All right, I'm running out of time, but these bispecifics can also work in a way where we can make them so they can cycle through different proteins. So once one stops to work, we can give another one to continue to bring those T cells in to recognize difference. I won't talk a lot about TIL, but we'll say all of this lovely data in the second line you heard that led to its approval. And the idea that it works in other solid tumors has already gone into a first-line trial. Early data in the first line shows good response, very small numbers of patients, but TILVANCE is accruing now, which is just a standard PD-1 versus getting TIL and PD-1 earlier, the first therapy that you get. Dr. Ferries is going to give you a great talk on that. No one's going to talk about poop after this slide, I promise. But this idea of trying to change your flora. If you get colitis, we've already done that. We're changing your flora, but in a good way, it's coming out. And there's been some early data that could work. It's a lot of work to change the flora and the fauna in your gut, but very interesting stuff, more to come. Hopefully in when you come to the 20th year anniversary, we'll figure out how to have figured it out. NK cells are cells that you've never heard about, really. There are other immune cells that are out there, and they're just hanging around. They're like that person on your basketball team that always gets in and never takes the shot, never defends. You hear about it, it's there, and you're like, I need to figure out how to utilize this person on our team. And this is where a lot of our research now is going, how to utilize these NK cells in melanomas. I love it. And we have antibodies that are like checkpoints for NKs that are in our clinical program now that stimulate the NK cells. This is a great one. That's off-the-shelf NK cells that come from other patients that are ready to give. We don't have a lot of experience in melanoma with it, but these are patients who failed in sarcoma, the hardest cancers to treat. And this is an off-the-shelf allo NK, which means you can just utilize it while you're waiting for your TIL to grow or once it's something else. And it has shown responses in heavily pretreated sarcomas. And I think the bottom one was a lung cancer, but we have more to come from that and some of the other academic partners that are getting into that. So as I come to a close, I will say that this is my favorite meeting of the year, not just because I get to see everyone, but I get to drag these two people with me, and we get to hang out for a dinner and to talk, and actually have had the wonderful ability to steal their slides and hitch on to the work that they're doing. It's great. You'll never find a picture of me with them without a big smile, I will say. And then I will thank you and say that we are, please save your questions. We will have a break. And then at the end, we're not having a break now, but we will have a break in the middle of this, but at the end have questions and answers and everything. And with that, I would like to introduce you to Dr. Untitled Chapter, who has come and now is spent more time in his career with us than anyone else, and is wonderful. One of the things that is important to me is coming and working with someone who has just pure energy and an interest in building program. And it's great to have a partner to build. And he'll tell you about a place where we're not really making as great of a breakthrough in some of the rarer melanomas. And so I will start this and bring Dr. Memi up.
Not as tall. So I'll lower this. No, I think those days are done. Thank you, Aim. Thank you, Sam, for letting us talk about some of the most important things that we could do to improve our patients' lives and continue to improve care for melanoma, and perhaps the knowledge we generate in melanoma, lending it to other malignancies to improve quality of life, disease control issues in that space as well. So the topic that I'm given today was actually difficult, I thought, because I'm to talk about disease or sub-diseases in melanoma space that we don't know a whole lot about, and why does it happen? How can we go after it? The thought is, if you don't know why it happened, how can you cure it or control it? But I think we're taking some baby steps that are allowing us to lead into that space where we can talk about what Dr. Hamid talked about earlier in typical skin melanomas, where the response rates are great, where the durability of these responses is amazing. And then we're talking about survivorship after 5 years, 7.5 years, and 10 years. I think all those things are important, and we want to bring those into what my topic of discussion is, which is uveal melanoma, mucosal melanoma, and acral melanoma. And I'm going to try and give you a little bit of what the current state of care in these sub-disease melanoma space, and then what are some of the unmet needs. I think there's a lot more unmet need than there is standard of care to be. So my objectives of the talk today is give you a little bit of background in all these 3 different subspaces, what is the current state of care, and what are some of the future directions. I wanted to give you a pictorial here. The uveal melanoma, there's 3 different compartments where the uveal melanoma can develop, and mucosal melanoma can happen anywhere from mouth to anus. And acral melanoma is essentially in the palm or in the sole of the feet, and also in the nail bed. Okay. So we'll start with uveal melanoma. Dr. Hamid talked a little bit about some of this space. Again, it's one of the most common primary cancer of the eye in the adult population, but it represents only a small fraction of melanoma in general. About 2,000 cases per year in the US and about 8,000 globally. So not a huge space in disease, which makes it difficult to conduct clinical trials that will generate reliable data leading to approvals. And that's why the progress in a lot of these small rare disease subtypes tends to be slow, because we just can't generate enough reliable data. Trials tend to be small. And then, we always doubt these trials, like, hey, this is only 40-patient trial. How can you rely on that and put it into practice? So we also know that, in early disease where it hasn't spread to, beyond the eye, we know that we can pick some of these patients out and watch them closely, perhaps institute some therapies early when they are without any metastatic disease, to see if, we can spare them of the metastatic disease in the future. And, doing gene expression profiling, that's what GEP stands for, and the PRAME, on these uveal melanoma cells, you can classify these melanomas into good versus bad categories, and perhaps take the bad or poor risk categories and treat them early enough and save them early. Okay. So that, taking the bad actors in early disease and acting on them, giving them some sort of therapy, let it be oral drug or IV drug, see if we can prevent these recurrences. It hasn't been very successful in uveal melanoma so far. There have been a number of trials. All of them have been relatively small in numbers, and that's probably one of the reasons why that data can't be relied upon. But there are ongoing efforts in drugs that are approved in metastatic setting, for example, Kimtrac or tebentafusp. We'll talk a little bit about that. That's being we're trying to bring that into adjuvant setting and see if we can prevent some of those recurrences, and that's the future we'll talk about. So when somebody has recurrences from uveal melanoma, there are a number of different options available if the disease is localized in the liver alone. And one of the slides that I went from, it's a predominant number of patients with uveal melanoma. When they do recur, they tend to recur in the liver, or liver with another organ, and that comprises about 90% of the patients. And so the thought is, if it's liver-only disease, why not just treat the liver itself? And that's a good thought, and it's brought reasonable amount of disease control, spared people of systemic side effects most of the time. And if they do have systemic or whole body side effects, they tend to be for a limited period of time. And for that purpose, you have a number of different options. There are different embolization procedures, chemo or immuno, radioembolizations, where you're giving the radiation beads to the tumor area, and hepatic artery infusions. And I'm going to talk a little bit more about that today, and trying to control the liver-only disease. So for that purpose, let's talk about percutaneous hepatic perfusion, or PHP, with melphalan for patients with ocular melanoma with liver metastases. And this is the focus trial that actually led to approval of this procedure from a company called Delcath. And it's, like I said, it's FDA approved. And they looked at two groups of populations where they got either the melphalan infusion or standard of care, and led to improvement in progression-free survival and overall survival. And based on this data, this therapy is approved. And I think we're getting ready to the point where this therapy will be available through the Angeles Clinic. And I think it's a great step towards another tool that we have for our patients to control their disease. This is the second hepatic infusion trial that, again, shows great results and in controlling the disease, improving progression-free survival, but it's not an option that increases overall survival. And that makes sense. If the disease is going to cause death in a patient, it's probably all over rather than just liver alone. So here we're attempting our efforts to disease controls in the liver only, and we're ignoring the rest of the body. So that probably translates into that, you have good benefit in sort of delaying those recurrences and other places or in the liver with this liver-directed therapy, but you're really not focusing on the whole body. And so that's why we don't have a good overall survival benefit with this approach. So we also know back from the CML days that most of these cancers have some sort of their cellular machinery signal mistakes, right? In CML, it's the Philadelphia chromosome. In skin melanomas, it's the BRAF or the NRAS or NF1, some of those gene mutations that sort of lend this gear to the cancers that puts in a drive. And for skin melanoma, we know we have 3 different combination oral drugs that we could use to turn that gear off. And we're trying to find that in uveal melanoma as well. And I think we're there. Okay, I think we're there because the earlier data targeting PKC and MEK inhibition is probably that. And this is an IDEA study from biopharma named IDEA, is IDE196, which is a divarasib combined with crizotinib. And it shows a very good disease control rate, perhaps overall survival benefit as well. And this is currently going in phase 3 study where patients who are HLA-A*02:01 negative, they'll be randomized to either this combination of divarasib with crizotinib versus standard of care therapies. And I think it's going to show that this is probably the first oral combination that's going to be available for our patients. So we also, one of the things I didn't mention is that the uveal melanoma itself is sort of an immune barren. It's not very inflamed or the hot tumor that Dr. Hamid was talking about. But there's still a subgroup of patients that can benefit from immunotherapy. So this is the trial that Dr. Patel led over at MD Anderson when she was there, and looked at nivolumab and ipilimumab in metastatic uveal melanoma and showed that about 20% of the patients actually benefit from this approach. So now we're looking at, we've got 100 patients. How many can we sort of, control with the tools that we already have in our box? And the ones who can't be controlled, what are some of their options, right? So it's always amazing when there are 2 different groups of people studying the same phenomena show the same results. It just shows you the strength in that concept. So not only Dr. Patel's group showed this benefit, but the same data or similar data from Spain showed the same thing, that there's about 18 to 20% of the patients in uveal melanoma that are metastatic. They can be controlled with ipi-nivo. But the challenge with ipi-nivo we always talk about is the toxicity. The dose that we use in the uveal melanoma space is a higher dose ipi. and low-dose Nivo, and that comes with about 50% toxicity risk of grade 3 events, and that's severe colitis or dermatitis or any kind of itis that you can think of. So, and then this is the third immunotherapy options that Dr. Hamid hinted towards, which is tebentafusp for Kimmtrak, FDA approved. Now we have 3-year outcome data that's persistent overall survival benefit. One of the things, sort of the difficulty in using tebentafusp is measuring who's responding from our traditional testing, for example, CT scans or PET scans. And so we're using ctDNA, circulating tumor DNA, the DNA that is shed by the tumor itself and into the bloodstream, and we're able to test it. And if that DNA level is decreasing, that's a good indicator that these patients are responding, even though their scans may not show that. Okay. And there's a concept of treating somebody beyond progression, meaning the scans show the disease is getting bigger. But this trial showed that actually people who were kept on Kimmtrak after their initial scan showed that their disease is getting worse, they actually had overall survival benefit. So that's a huge concept in immunotherapy. I don't think it's such a huge concept in anywhere else, but in immunotherapy, it's a huge, even for non-uveal melanoma patients, we often look at their first scan, and if the progression is not significant, if their clinical status is not deteriorating or their organ function isn't deteriorating, we tend to keep them on the same therapy they've been on. And in a number of patients, you can see on a subsequent scan that the disease is actually getting smaller. Saying that this is a concept, and these concepts come into play at center like this, at center where Dr. Sullivan's from, and with Dr. Patel's center, because that's where the expertise is. And that comes back to what Dr. Hamid's saying, have your local oncologist, just chat with the expert and give them their opinion so we can take care of these patients the best way we know how. Dr. Hamid already talked about this. This is the next sort of T-cell engager, the matchmaker, targeting a different antigen on the cancer cells, PRAME, and it also showed that uveal melanoma is probably a good space where this will have activity. The initial data shows that, yeah, that is the case. And now we're hearing about T-cell tumor infiltrating lymphocytes in skin melanomas. We're hearing about it in cervical cancer. We're hearing about it in non-small cell lung cancer, a number of other spaces. And why not in uveal melanoma, right? But it's been challenging. The response rates or disease control rates hasn't been as good in uveal melanoma, perhaps because it's not so inflamed tumor in a sense. So this was one of the initial trials, and at MD Anderson last year at ASCO, another trial was presented where at least we're seeing that we can generate these TILs from the tumor, and that gives us the ability to at least infuse them back, see if we can control the disease. Also, they're looking at additional protocols. Usual time from TIL harvest to treatment, what Dr. Ferry is going to talk about, is about 4 or 5 weeks. Is there any way to shorten that time period? And I think there are a number of protocols in practice to, or at least in research, to see if we can do that. This is one of the trials that we just almost completing at the first phase of it, which is combining tumor treatment fields with immunotherapy. And I think within about the next month or so, we'll have the first 10 patients accrued, and we'll analyze the data and go to the next step. This is actually one of the more exciting trials that I've seen come out recently for uveal melanoma. SD101 is a toll-like receptor agonist made from bacterial DNA. There are some fundamental differences between our DNA and bacterial DNA. And by using these oligonucleotide short pieces of DNA and injecting it into the tumor, we're able to make these tumors more inflamed. Okay, I was part of the initial trial when I was at West Virginia University, where we treated patients with melanoma and head and neck cancer in combination with Keytruda or pembrolizumab. And that work is already published in JCO. And now this company, the initial company actually didn't pursue this any further, and the rights to the SD-101 were bought out by another company called Translational. And what they're developing is for how can we infuse this SD-101 into the liver metastases of a uveal melanoma patient and have the most impact. And they've developed a specialized catheter and delivery of that drug, infusing this SD-101 into the liver and making the concentration of this drug highest possible. And they've shown really good results, very good disease control. And I think Dr. Patel was part of this group as well. Okay, now that we talked about uveal melanoma, I gave you some what's the center of care and where we're going in the future. Let's talk a little bit about mucosal melanoma. I know this is a busy slide, but I wanted to talk about a few things. Again, mucosal melanoma is not very common, right? And we don't know what the risk factor for mucosal melanoma is. We know a lot about skin melanoma risk factors, but we don't know a lot about the risk factors in mucosal melanoma. We know just a tad bit about the risk factors in uveal melanoma, but mucosal melanoma, like I said, the median age is about 70 years old, and there are no racial differences. For example, cutaneous melanoma is more, it happens more often in Caucasian population, but mucosal melanoma doesn't have the same predilection. And the primary mucosal melanoma can happen in the respiratory tract, your upper or lower respiratory tract, lungs, trachea, bronchioles, or gastrointestinal tract from mouth to anus, or genitourinary tract. And then also mucosal melanoma, when you look at some of the genetic signature of the disease, it's entirely different than what skin melanoma does. And also what I wanted to highlight is that the mucosal melanoma that happens in upper portion of the body is actually different than when it happens in the lower portion of the body. And perhaps that can give us clues in how to pursue these patients, these treatments, and how can we tailor make their treatment options. And then that's the future. So these are the two trials that I think Dr. Hamid's already brought up, and they're going to be brought up again and again. These are some of the key trials that have happened in melanoma in general. And mucosal melanoma was a reasonable chunk of these trials, and that allows us to at least make some decisions for patients since we don't have a lot to offer in this space. So Ipi-Nivo or Opdivo and Yervoy, CheckMate 067 had about 40 patients 79 patients with mucosal melanoma, and they have at least 5 years of follow-up. And, they're a reasonable, sizable, group of patients that we can actually help. And what we don't know from that CheckMate 067 trial is where was this mucosal melanoma? Is this head and neck mucosal melanoma, or was it GI tract mucosal melanoma, or where was it that benefited the most? I think we're learning that perhaps the head and neck melanoma, mucosal melanoma, is probably more responsive to immunotherapy than the other parts. And Relativity 047 that led to approval of Opdualag or nivolumab and relatlimab, that also had a sizable portion of mucosal melanoma patients showing that they may benefit from a progression-free survival, but we don't know what the overall survival benefit when you're comparing one drug versus another. And the last little slide at picture at the bottom, we were part of this retrospective series with the Australian group, and looked at, is it, when you're looking back, there are a lot of pitfalls in that kind of study, but sometimes we can gain some insight. A patient's coming in with mucosal melanoma, they're not doing all that well. Should I pick a combination treatment for them with higher toxicity, or should I go with one drug? Right here, this retrospective, probably one of the largest retrospective series, showed that the using combination versus one drug didn't really have all that much of a difference in overall survival. So, a lot of the time we'll push a combination to get a better punch at the disease. But if that punch is going to cause pain to the patient as well, maybe we should step back and say, okay, let's just use one drug, since some of the information that we have doesn't really show that we could use 2 drugs and get better benefit. I know I'm kind of going against what Dr. Hamid earlier said about combining all the tools, but using it in a context. Okay, and what else is happening in mucosal melanoma? So we've known this for a while that, some of the mucosal melanomas are very dependent on sort of different signal transductions that the cellular machinery, and some of that could be targeted with drugs called multi-tyrosine kinase inhibitors. And when we combine it with immunotherapy, we think we can pack a better punch because there's a modification of tumoral microenvironment that allows these immune therapies to work better. And there are 3 different studies that kind of attempted the same thing with different PD-PDL1s in combination with these small tyrosine kinase inhibitor, or bevacizumab, which is a VEGF, vascular endothelial growth factor inhibitor that sort of rearranges the blood supply and also some tumor microenvironment changes. Again, all of them show that, there are reasonable methods to control the disease. All of them are showing pretty much the similar response rates. These are, again, small trials, and they would have to be looked at in a larger set of patients to make our case for these drugs being used in average patients. Again, TIL, tumor-infiltrated lymphocytes, if it's good in skin melanoma, is it good in other melanomas? Initial signal is that possibly, it's a small subset of patients, 12 patients, that TIL was used in a larger cohort of all melanomas and showed overall response of 50%. And we haven't seen how long this impact's going to last. So that will be forthcoming. And I think a larger trial will be needed and is ongoing to make this option a viable one for our mucosal melanoma patient. Acral melanoma, right? So that's my last and third rare melanoma. Again, it's a very small fraction of all melanomas, and it doesn't have any relation to, even though our palms and soles at one point are exposed to sun, but we don't think it has that relationship with the sun exposure. Neither it has the relationship to having a light skin, light color of eyes or hair, as the other skin melanomas do. Family history doesn't seem to play a whole lot of part in it, or any kind of pre-existing mole on the hands or feet has it. And but non-Caucasian population seems to be at a higher risk. Okay, so this is, we always talk about melanoma in Caucasian population. I think this is where the other subset of population needs to watch out, right? And also wanted to talk about, so when we're looking at the genetic makeup of these melanomas, there's no one sort of genetic mistake that stands out in this melanoma. There is no sort of targetable, that BRAF kind of mutation that we can target. Only about 5% of all acral melanoma will have a BRAF mutation that's targetable. But the environment of acral melanoma, there's the melanoma, and then there's the supporting environment or inhibitory environment. That seems to be completely different than what skin melanoma has. The acral melanoma's microenvironment, the surrounding, it seems to be supportive of melanoma rather than inhibitor of melanoma. And in skin melanoma, it seems it's a little opposite, or the non-acral melanoma skin cancer. There hasn't been one particular trial that focused on acral melanoma to see how well we can or cannot control. Acral melanoma, just like mucosal melanoma, has been part of most of the melanoma studies and show that there are, a reasonable patients that could be controlled with regimens that are available for other skin melanomas. And as such, Relativity 047 that led to approval of Opdualag or nivolumab or relatlimab did have acral melanoma, about 40 patients in each subgroup. And we don't know if the combination is better or one drug is better. Again, something that we need to study, because this is a small group of patients. Are we losing that combination signal because these patients are just too few? right? But there is benefit of immunotherapy in general for this group of patients. This is one of the larger series of acral melanoma that was published, again with the Australian group, and we were part of this as well. And again, it showed that there is, when you're looking back again, the pitfalls of a retrospective series, keeping that in mind, with the combination approach, we haven't seen a significant difference rather than using single agent. Is it the function of a retrospective series? Is it the function of combining patients from different regions? Is it a function of single agent is just as good as combination in melanoma? We don't know. I think a lot need to be studied, and then we'd be able to answer. Again, immunotherapy is active in acral melanoma, and we should that's the frontline therapy we always think about. In summary, all these 3 melanomas, they're rare. And some of these, well, actually all 3 of them, we really don't know what the risk factors are. And adjuvant therapy or post-operative or post-primary disease treatment, role of adjuvant therapy is in uveal melanoma, it's developing. In mucosal melanoma, don't really know at this moment. And there is developing story for neoadjuvant therapy, meaning trying to, when patients is diagnosed with localized mucosal melanoma, giving them treatment before they potentially go for surgery. I think there may be benefit of that, and that story is still developing. In acral melanoma, we always we borrow the data from non-acral skin melanoma, and we do use neoadjuvant, we do use adjuvant therapies, but the benefits may or may not be similar. And the systemic therapy, again, the list is growing in uveal melanoma, and in both the acral and mucosal melanoma, that story is still developing, even though we're borrowing a lot of the concepts and trial data from typical skin melanoma to manage our patients. Okay, thank you.
Yeah, on time. Huh. All right, well, Dr. Memi just showed you how hard it is to translate some of those benefits that we get from skin melanoma to other melanomas. It's even harder to translate it to other cancers, but it's happening. And the main indicator of that is how we're utilizing these therapies even before the cancer spread to other organs in the adjuvant and neoadjuvant. What the hell does that mean? Because we've been throwing those terms around. Well, I can't do it as I can't give that talk or educate you as well as Dr. Patel. Dr. Sapna Patel, who is a leader in that field, and is then last year we kept saying MD Anderson, and now Dr. Patel has moved her expertise to the University of Colorado, and I've got to get used to saying this. She is the William Robinson Endowed Chair Professor in Cancer Research. And we celebrate that and the recognition of all the work you've done, which she will tell us about right now. As you don't need a timer.
11 minutes. Thank you, Dr. Hamid. I just realized I've made a boo-boo. So this talk is only going to be about neoadjuvant therapy. I didn't actually include anything on adjuvant. I just realized. That shows my bias, doesn't it? Okay, so this was entitled Questions Getting Answered. So I framed it in a bunch of questions and answers. Well, I've got a good title slide. I don't have the rest of my slides. And next, I'm on time. Probably we just need to swap an order, maybe. Yeah, what if I did it with no slides? Could we do it that way? Not even much. The first question is, Yeah, let's do that. So neoadjuvant, neo means new in Latin, and then adjuvant means alongside, basically. So lovely. Don't look, close your eyes. So adjuvant therapy is what we give people after primary treatment. So after a primary tumor and or lymph nodes are treated, is there something we can do to reduce the risk of cancer spreading? Neoadjuvant is something you might do before treatment of the primary tumor. And it may come with some adjuvant therapy post surgery, if you will. Some people are using the term perioperative because that more clearly explains that it's something done around the time of surgery, before or after surgery. So one of the first questions, I think, is there any rationale for giving medicine before taking out a cancer? And it turns out there is. There was a nice, you can just picture it in your head. There was a nice breast cancer model that did this, a mouse model that said if we inject a little breast tumor in the mammary fat pad, so essentially the breast of a mouse, and then just let it grow into a tumor and take it out and look at the immune system, how much immune system do you have after the fact? And if we actually do some treatment, and in this case, they did a type of kind of tetanus diphtheria toxin, which is known to stimulate an immune response. If they give that while the mammary fat pad tumor was growing, would you get a bigger immune system after taking out that tumor? So when they compared those mouse models, they did see a bigger immune expansion in the blood of the mouse. So that was really the original. Oh, here we go. Slides. That was the original model for neoadjuvant therapy that was sort of modeled, if you will. Boop. Boop. Boop, boop. I went back to. Yeah. So then this was done in actual melanoma patients, just as a pilot study. And they took 20 patients and gave 10 patients who had their melanoma that was able to be removed. They took it out and gave them what we call adjuvant immunotherapy. Let's try. Yeah, here we go. Okay. So questions, answers, this is where we are. Is there rationale? Sure, there is. This is the breast cancer model, but here's the sort of skin. This is just a cartoon. This is not, obviously, this was not done, but the idea in the top is if you take out a tumor and then give some drug therapy, you'll get some of these colorful circles, immune cells activated. But if you leave the tumor in place and give the drug, then those Y molecules actually get a bigger number of these circles, as you see. You can still take the tumor out, but the idea is you're left behind with more of this circulating immune system that can then go off and do stronger work. So that's the rationale. And, I guess before we get to that pilot study in melanoma humans, it's important to recognize what the scientific method is. This is how we properly test things in, across science, but in medical clinical trials. You make some observation that it may make sense to leave a tumor in place for a short amount of time to expand the immune system, but then you have to design an experiment around that. And then you have to have some hypothesis of what will happen. We hypothesize the immune system will be more expanded if we leave the tumor in place for a short period of time. But then you actually have to test it, and then you have to describe your observations. So, sometimes you make slime and the slime looks good, and sometimes you make slime and it bubbles over. So now you have to go back and say, okay, what actually happened here? What did I observe? And then it's iterative. You go back and do that again and again, and make your observations, make a experiment, hypothesis, design or describe your results, etc. So this is how we kind of do things, and it all starts with a pilot study, which is what this Opacin or Opacin trial was. This was the optimal dosing. The way to sequence immunotherapy perhaps before you remove a tumor. And so what they actually did, let me see if I can use this pointer. The pointer is, which one is the pointer? The red, right? Okay, well, it's not working. All right, it's fine. In the adjuvant in that red bar up top, they had these melanoma tumors, took them out and gave them adjuvant therapy in 10 patients. And then in another 10 patients, they gave them treatment first, then took out the tumor, and then more treatment on the back end. And essentially what you see in that blue group is you got the bars are taller. So you got more of an immune system by leaving the tumor in place for a short period of time. And you got new T cells emerging. So that's the faded, the lighter color blue, if you will. So you got kind of essentially more clonal expansion of new T cells, new detected T cells by leaving it in place. This is all nice. So this tells you what they found in mice and breast cancer you could somewhat replicate in human melanoma patients. But at the end of the day, does it prevent the melanoma from coming back? You know, do you live longer with this strategy, or is it just a nice way to boost your circulating immune system? So this gets to the question, let me go back here. You know, this schema gave 2 rounds of immunotherapy combination while leaving the tumor in place. But could you have done 1 round, or could you have done all 4 rounds? How much immunotherapy do you need while leaving a tumor in place? And that gets to how much duration of this preoperative therapy and maybe adjuvant therapy do you need? So this is a slide that describes all of the essentially single and double institution trials that looked at this preoperative and postoperative, perioperative, if you will, approach, with the gold being the preoperative regimen duration and the blue being the postoperative. And you can see it's across the board, right? There are some medium regimens, 8 weeks, 12 weeks, 6 weeks, 12, 3. There are some regimens that have no adjuvant therapy. So that bottom group, they just gave the preoperative with no postoperative. There are regimens that gave a full year. There are regimens that gave a total of a year, half a year. So do we know the optimal duration? Based on this, there's no unifying answer, right? You could say, you can't draw a straight line and say this is exactly how much to give. So the answer is we don't know. And even this International Neoadjuvant Melanoma Consortium doesn't know, which is okay. It just means we're just still experimenting with different durations. But I would sort of, you know, for the scientists in the room, I would remind us of some of this very, very early data in the metastatic setting. The way these immunotherapies work is typically they're blocking a receptor. So they're blocking an interaction on a tumor in the immune system. And we call that receptor occupancy. When you block a receptor and you sit there for a period of time, it doesn't just block it and fall off. It blocks it and holds onto it for many weeks. And so the question is, how many doses until you get excellent blockage of that receptor? From our metastatic data, this is way back, 12 years ago, we knew across different dose levels of the drug that turned out to be nivolumab, after 4 doses of every 2-week dosing, so, this is about 8 weeks into therapy, the receptor is saturated at about 60 to 70% after 4 doses. And it doesn't matter what your dose was, whether it was one of those low doses, 0.1 milligrams, or one of these higher doses, 10 milligrams per kilogram. You're about 60 to 70% saturated. It still doesn't tell us how much of that happens after the first dose, how much of that happens after the second, third, and fourth. And theoretically, we could design a trial like that, where we actually gave patients who have resectable melanoma these single doses, 2 doses, 3 and 4, and we look at this endpoint that we look at in perioperative trials called event-free survival. We could also look at receptor occupancy. So we could see how much of the receptor is actually blocked after 1, 2, 3, and 4 doses, and maybe try to get to this answer of the optimal dose. The point being, if a lot of it is blocked after that first dose, then second, third, and fourth doses may only be adding to toxicity and side effects and not so much efficacy or effectiveness of the treatment. Okay, well, that's all nice. That tells you we've got some rationale. But do we actually have any randomized data in this setting, in this perioperative or pre and post surgery? We do. There's a couple of trials. The SWOG S1801 trial was a cooperative group trial that we ran in the US, where we randomized patients essentially to how that opposite trial was done. Patients who had resectable melanoma could get randomized to the standard of care. That's the top row. So they would have surgery and then a year of standard pembrolizumab post-operatively in the adjuvant setting. or they could have perioperative pembrolizumab. So they would take 3 doses before surgery, then go to surgery, and the remaining 15 doses in the adjuvant setting. So this study just said, same treatment, let's just split it up and sequence it a little differently. And what we found was actually the group that took it before and after, the neoadjuvant adjuvant group, could call this perioperative, they did better in terms of melanoma events than the group who took it all post-operatively. So this was randomized now human trial data that said you do have better outcomes. It doesn't answer the question that original Opposin trial showed, which is, do you have more circulating immune system? We haven't shown that. We haven't looked at that yet. This is just the more clinical, tangible endpoint is, do the patients do better? So we hypothesize that it's due to a boosted immune system, but clinically we see that these patients are doing better. And this is just a side note. We didn't put the hazard ratio in the New England Journal paper because we had this cranky statistical reviewer who kept fussing with us and said, you cannot put this hazard ratio. These are non-proportional hazards, which is only to say they didn't think our 2 groups were actually proportional at baseline, which is false, but because you entered the study and then you got randomized, so they were proportional. And all these other neoadjuvant therapies published their hazard ratio. So we had this cranky reviewer, and we just decided better to get it published than to fight with the reviewer. We submitted the paper in August. It was actually in print in March, and we were accepted in December. So it's this long road. And if we had kept fighting, no telling how long. But what the lesson learned is that regulatory agencies around the world, so Finland, Denmark, all these countries are looking for that hazard ratio for their health ministries to approve these therapies. So the absence of that hazard ratio really caused a lot of these global health agencies to have pause about accepting this regimen, but nevertheless, so that's that. Okay, so once again, this study, this randomized trial really only tested one hypothesis, and that was you have a fixed amount of pembrolizumab. Can we just alter the sequence? It doesn't tell you that we chose the optimal sequence or the optimal duration. We said 3 doses, but maybe 1 dose would have been enough. Maybe 6 doses would have been better. It was just a single question, and we chose 3 doses just because it approximated a reasonable amount of treatment without delaying surgery too much. Now, there was another randomized trial in this perioperative space. Really, this was a pure neoadjuvant preoperative study, and this was an injectable, essentially light herpes virus, a deadened herpes virus that we inject into tumors. And herpes is essentially a very strong stimulator of the immune system. So you inject a non-infectious herpes variant into a melanoma tumor. It will stimulate the immune system and it will draw it over to that tumor. And now that immune system will say, well, what's all this melanoma stuff? And start to treat that. So this is an injectable therapy, TVEC, telimagene laherparepvec. And this simply just said everybody either goes to surgery or we inject them 6 times. So this is over the course of a few months. We inject that melanoma tumor 6 times and then we remove it. And it turns out doing that injection did give you a better survival. So that's the gold arm here. And you see it not only in that recurrence-free or what we call event-free survival, really it's a recurrence-free survival here. You see it overall, those patients who got the injections did better. But this is not a typical way we're treating melanoma right now. We're not injecting it before surgery. There's also some caveats about like how the study was done. It wasn't done in the United States. And we always take a little bit of pause if we don't have actual US patients in these trials. Is the data sort of real world enough for us? But having said that, this was another randomized trial that's out there in that space. So now the question is, if it looks like leaving the tumor in for a period of time and doing something, whether it's immunotherapy, via vein or injecting some form of immunotherapy, if that looks like it's beneficial, are we ever going to get to the point where we can do less surgery for melanoma? So it's no longer a lot of surgery, lymph node dissections, et cetera. And can we do less post-operative, so less adjuvant therapy? So how do we answer that question? The Prado study attempted to answer this. Now, this Prado study, I make the point when I look at the slide, it's a really pretty slide. It's a pretty schema. But it's important when you think about that scientific method. That scientific method is testing a hypothesis. And this is not actually controlling for any of the variations. So this slide looks very pretty, but it's not a randomized trial. So there's no randomization here. You just start marching down the study. And if you have the green outcome, you go into that group. If you have the gold outcome, you go into that group. If you have the red outcome, you go there, but you don't randomize. So you don't randomize green versus gold or green versus, this regimen versus another regimen. That's all to say it's still an excellent study. It is a personalized strategy. So if this happens, then you do this. If this happens, then you do this. As a result, there's a number of variables that ended up here. So this study de-escalates surgery and adjuvant therapy, and you see that in that final column of boxes. If you have an excellent outcome at surgery after being exposed to pre-surgical immunotherapy, you're finished. You don't have to have a big surgery, and you don't have to have adjuvant therapy. The partial responders, the gold box, had a full surgery, but they did not need to have post-operative or adjuvant therapy. And so those are just additional variables introduced into the analysis of this. I think that's my monitor dinging here. Okay, so this study had a very interesting outcome for these major pathologic responders, this green group of patients. They're doing very well. You see that tail or that plateau developing for these patients. They're clearly doing very well. But the hypothesis, we go back to the scientific method, what was their hypothesis? The hypothesis was that none of these patients who accomplished a green outcome would have a recurrence. So nobody would recur in the first 2 years. And they did have 4 of these recurrences in the first 2 years. So technically, by that endpoint, this was a negative study. Their hypothesis was something, they didn't meet their hypothesis. So they went back and looked at their observed data. They also said in the gold group, this group didn't do as well as we thought they were going to do. Based on the prior experience, they thought this gold group was going to be fine just having surgery and no adjuvant therapy, but they ended up not doing so well. So this helped them think about kind of the next trial design, what to do if you have a gold outcome, you probably still need some adjuvant therapy. And so there were 2, it's a very, very important study because it shows us that we can kind of revise or iterate our hypothesis based on previous findings. Now, this is that same green curve that we see here. I'm just showing it to you isolated here in terms of relapse-free survival, so the melanoma coming back, and that's in any form, at the lymph node site, distantly somewhere, and then just the distant survival. So did the melanoma come back somewhere distant from the original? So what's interesting is there were these 4 patients who developed a recurrence. And remember, this is the group that didn't have a full surgery and didn't have adjuvant therapy. And what the authors are saying is, well, when the patients entered the study, these 4 patients had multiple lymph nodes involved. So they may have been patients who, were going to have some recurrence. We maybe could have picked them out because they had more than 2 lymph nodes, not just 1 lymph node involved. And they were raising the question, well, would we still ask this whole group of patients to undergo a full surgery when only maybe 4 recurrences happened? And ultimately, we only had 28 patients who had more than 2 lymph nodes, and it was still only 4 of those 28. Does everybody need a full surgery? It's only 14% recurrences. Would we subject 100% of these patients to a full surgery? So the conclusion of the authors is that you could probably omit surgery for everybody. I will just make the caveat that that's a fairly controversial statement, because if you as a patient are one of those people in whom the melanoma recurred, you may have preferred to have had that big surgery up front because you don't want to have a second episode of melanoma, et cetera, et cetera. So this is a little bit controversial. It's which perspective you're looking at it from, the 14% or the 86%. Okay. What else is I going to tell you about this slide? That's probably it. This is the real question. If we know somebody has multiple lymph nodes involved at the beginning, should we maybe keep the full surgery for them? It's still going to only be a minority of those patients who have potentially a recurrence if we omit the surgery. But are we doing the greater good here? That's a philosophical question, I guess. The last thing to say about this trial is that omission of surgery is still considered a little bit controversial in some of the surgical literature. So could you actually remove the surgery for all of these major path responders? We're not sure. And there's this editorial that suggests that a full surgery should remain the standard of care. And for that gold group, that group that has a kind of an intermediate response, could you just do surgery? Do you not need the post-operative adjuvant therapy? That's not really clear either, because that group certainly didn't do as well as hypothesized. So where do we go from a study like Prado? They used all of that information and built it into this randomized study called NADINA. And NADINA is a global study that randomizes patients to the standard of care, which is the bottom row. So a full surgery for their melanoma and then post-operative therapy for a year. Or they get randomized to the neoadjuvant, which is 2 doses of immunotherapy. And then based on what happens at the full surgery, if they have excellent tissue response at the full surgery, they're done, no adjuvant therapy. If they have less than excellent response, then you'll get some form of post-operative or adjuvant therapy. So NADINA is finished. The study has finished enrolling. And the real kind of big news is that we should stay tuned. And what are we, like 3 weeks away now? 2 weeks away from hearing this? What date is it? Today's the 11th. So we're about 3 weeks away from hearing the results of this. This will be in the big plenary session at ASCO, so our big international conference, and we will hear the results of this NADINA study with a good discussion by Harriet Kluger and Christian Blank, who's really the leader in this neoadjuvant field. This is who you should have come speak at your Angeles Clinic forum, because put him on a ship. He'll come by boat. He'll swim. He's a swimmer. So Christian did that original opposite work, that pilot study work of 10 patients in melanoma, and helped optimize, how we invert the doses in the neoadjuvant study. I mean, he really is a leader, and this is such a wonderful opportunity for him to showcase this big NADINA trial. Okay, so that's talking about, perioperative, and we're going to see some nice randomized trial data on combination immunotherapy. What about that post-operative? What if we gave everybody the same neoadjuvant regimen? We gave everybody the same surgery. How do we determine how much post-operative we need? If we go back to NADINA, remember here, we're not really controlling for what happens in green and pink here. So what you'd like to see is major pathologic responders. Then you get randomized to dropping adjuvant therapy or continuing adjuvant therapy, right? And then you could say, okay, they do or do not need adjuvant therapy. But here we're just dropping it. So if they do well, that's great. But if they don't do well and there's some recurrences, you'll question if they needed some adjuvant therapy. So what if we just did that trial, which is give everybody the same regimen, take everybody to surgery, and then randomize them to no adjuvant therapy, some adjuvant therapy, half a year, the full year, which would be 10 if you give 2 rounds before surgery. And then you start stratifying them by how well the tissue responded. This would be a large study, but it's completely doable. And so this is something where we could actually figure out how much post-operative therapy people need. Okay, what's the next question in this space? It's really, if we are now adopting this perioperative approach, and globally, this is really now being used for resectable or operable melanoma. So Australia can offer perioperative pembrolizumab now. The UK can do it. Ireland can do it. There's some countries in Europe that can do it. They can do it with single agent immunotherapy at the moment. After NADINA, hopefully they can do it with combination. So you're now using these regimens. The patient is sitting in front of you. They've just had their surgery, and you've given them that pre-surgery treatment. The most important question, I think, is not to discern if you've had an excellent outcome, because we can always, we do this comparison thing where we say, did this patient have the best outcome? Well, they can only have one outcome. You can know in your head that there's another patient that can do better, but that's not helpful for the singular patient, right? The real binary question for that one patient is, are you happy with this response, or are we feeling that it was unfavorable? Not did they have the best response, any patient can have, because that doesn't help anybody. So the way I like to frame this is, okay, now you've treated the patient, they're sitting in front of you. Are you going to say to that patient, I'm happy with what's happened. We have a favorable response here. Or what is the sign of an unfavorable response? So that's, I frame it in unfavorable because I think it's a little easier to put your head around. So we went back and looked at our SWOG trial and we said, okay, if we look at the tissue response after those 3 doses of pembrolizumab given before surgery, take out the melanoma and we look at the tissue response, what happens? How does it separate? And it turns out it separates into 2 groups, right? You see those 2 groups at 2 years here and here. I guess I just clicked because I circled it on the slide. I cartoon circled them. There we go. So there's a group there that clusters together. And you see in the table here, they have essentially the same 2-year recurrence-free survival, 87, 88, 89. Does it matter what shade of blue you got? It really doesn't, right? So you just want to tell that patient that's sitting in front of you, if they ended up in that bucket, you're happy, right? You're not unhappy if they had a non-response, let me clarify, but you're happy that they had one of these higher responses that bundles together. But what if you don't really have, the pathologists aren't really technically reading the tissue that way? What if you just use the radiology scan that you got before surgery? The patient had the treatment, you had some scan that showed their lymph node, then you had the scan right before surgery that showed the change in that lymph node, hopefully a decrease. Are there 2 groups here? It turns out there are 2 groups here. So there's the group that basically had a complete response on that imaging or a partial response, or stable disease or progression of disease. So we have 2 groups there, and they also segregate there, you see, with similar numbers for radiology. So now you've got the patient sitting in front of you, and you say, well, I like what happened to your lymph node before you went to surgery. So again, you're feeling, you know what favorable is. So then what is the sign of an unfavorable response? So let's go back and agree what we think favorable is. Favorable is we didn't give them any major side effects. We didn't give them any major side effects that we lost that surgical window. So they still went to surgery on time. We didn't have any progression of their melanoma before surgery because the melanoma was left in place. The risk that, and the fear that some patients would have, which is fair, is, well, or if we leave the melanoma in place, isn't it just going to spur on more melanoma? So as long as we don't have melanoma spreading before surgery, that's favorable. Can you get to surgery and still get all the melanoma out? That would be considered favorable, right? We want all of that melanoma out. Can you get the postoperative therapy? And I say that only because we're not really sure right now in whom you can omit that postoperative adjuvant therapy. So as long as you can receive some, we would think that that's probably favorable. And then ultimately the biggies, right? We want no melanoma recurrence and we want no deaths from melanoma. That's really favorable. Now that's a longer outcome, but that's going to be our favorable response. And as we expose people to more immunotherapy, we want the toxicity to be manageable. We don't want to leave somebody with a lifelong problem. We've fixed their melanoma and then we've given them this other thing. Ideally, we want to fix their melanoma and not give them a major side effect. Okay, so if that is all favorable, then I hope it makes sense that the opposite of those would be unfavorable, right? So if we get side effects and we lose our surgical window, that's unfavorable. That's how I would sit in front of a patient and say, gosh, I'm a little bit disappointed in myself that this regimen caused this side effect and we lost our surgical window. If we leave the melanoma in place and it does spread, boy, that's unfavorable too, but that's probably telling us the bigger picture about the biology of that melanoma. Taking it out may or may not have stopped it from spreading. If we can't have surgery to remove all of it, so the melanoma can grow, that's okay. Melanoma growing is not a failure or unfavorable response, because remember, we still have surgery on the table. We still want surgery to remove it, as long as that can happen. But if your melanoma grows or spreads in a way that the surgeon can no longer take care of it, that would be disappointing. That would be unfavorable. And if you can't get to your postoperative therapy because the surgery was too hard, the preoperative treatment was too hard, we developed some side effect and now it's contraindicated to give you adjuvant, that would be considered unfavorable. Obviously, if the melanoma recurs, that would be considered unfavorable. And then if you have one of these lifelong or serious side effects. So my answer to what's unfavorable, it's the opposite of what we're considering favorable, right? We like all of these things. If a patient comes to me with basically the opposite, I would say, that's unfavorable. And I say it that way because there is this feeling amongst our oncology brains that patients need to take a little bit of preoperative therapy and have all of their melanoma eradicated. And now we don't need surgery, and now we don't need adjuvant therapy. And if we don't achieve that, we're not happy with the result. But that's not true. That's not true. Just like you saw, Dr. Hamid showed you patients who have a complete response do well, partial response also has a tail of the curve. And then we have two other groups maybe that could be doing better. But once you're on that curve, if you're a partial responder, that's where you exist. Are we happy with the partial response or are we unhappy? Most people wouldn't be unhappy with it. We would just in our head do, I know there's a better outcome we could have. So just because your melanoma was not completely eradicated after your preoperative or perioperative regimen, it doesn't mean you had an unfavorable response. It means there's a better response out there, but it doesn't mean that the response was unfavorable to you. I'm getting a little bit philosophical here, but that's true. So ultimately, the sign of unfavorable response to perioperative therapy would be a recurrence of the melanoma. We would say that perioperative regimen then didn't work. So what is the goal of neoadjuvant therapy? Is it to eradicate all the tissue evidence of melanoma at surgery, a complete pathologic response? That's an optimal outcome, but that's not the goal. The goal, remember, is to boost the circulating immune system. And boosting the circulating immune system doesn't speak to eradication of the tumor in a short amount of time. That eradication may still take weeks and months and years. So complete pathological response is nice, but it's not required. It does not have to be the goal. Similarly, complete radiographic eradication. I can no longer see the melanoma on your scan. That's nice, but it's not required with a short course of neoadjuvant therapy. The real goal of neoadjuvant therapy is number 3 up here. It's to stimulate an intact immune system, leaving the tumor in place in situ to produce a more diverse and expanded T cell system while maintaining operability of that tumor. So if the answer, what is the goal, is number 3, what's the sign of that? How do we know that we've accomplished number 3? Well, it's going to be melanoma recurrence. If the melanoma never recurs and you live your entire life, melanoma free, then we know that that treatment has worked. We can say it's going to be boosting this immune system, et cetera. We need markers for how to measure that. So the pathology and the radiology may be surrogates of this. If you have a complete eradication, it may be surrogates. Although remember, that earlier study had complete eradication and there were still some recurrences. So we do need some more validation of this. Okay, the bigger question is, are signs of an immune response important when we do this perioperative immunotherapy? Of course it's important. We want to see signs of an immune response, but what does that look like? So when we take out tissue after exposing it to preoperative treatment, there's an entire chain of custody that has to happen. The medical oncologist has to tell the surgeon, hey, I gave this patient preoperative therapy. The surgeon then has to label the specimen as having been received with perioperative therapy or exposed to perioperative therapy. And now the grossing technician, a technician who sits in the operating room's tissue window, has to section this tissue very differently than if they were just looking for melanoma, yes, no. After you've been exposed to preoperative immunotherapy or therapy in general preoperatively, it's not just a melanoma yes, no question. We think it's actually how well did this treatment work, right? Which maybe is not the right way to look at this tissue, but this is certainly what the guidelines suggest right now. So that grossing technician has to section this tissue far differently than if they were just to get a lymph node and bivalve it, cut it in half and say melanoma, yes, no. They actually have to thin slice this technician, and now the pathologist has to read each of these thin slices. And this is not really accounted for in the way we bill, pathologists bill for their time, et cetera. The pathologist is now looking for these different categories of response. Do they see fibrosis? Importantly, hyalinized fibrosis. That's the sign of a long-standing immune response. Do they see pigmented macrophages? So not melanoma, but actually the little Pac-Man cells that are eating up melanoma. Do they see necrosis and do they see viable tumor cells? They then have to do math, and they have to do this on every sectioned slide from that lymph node and melanoma. Historically, all they would be doing is cutting that lymph node in half and saying melanoma, yes or no. So this is a much more time-intensive process for pathologists. And then they have to apply this response categorization. So based on how much residual viable tumor, is it a complete response? Is it a near complete, partial, or non-response? And that's complicated, as you can imagine. So my point here is if you look at that SWOG trial one more time, that randomized trial where we gave the pre and post-operative pembrolizumab, you see there's two groups, right? It's any type of response and non-response. It's not saying you must know if it was a complete response, right? So it's not a pathologic complete response and anything other than that. It's any type of response and non-response. So could we simplify this criteria so that the pathologist doesn't have to spend quite as much time doing it? That might help. This is getting a little bit in the weeds, but when we ran that trial at each of the individual hospitals, about 1 in 5 patients had complete eradication of their melanoma as read by that hospital's pathologist. But we asked all of those 150 cases to be sent in centrally. And we had one pathologist blinded to the results. Blinded Independent Central Review is what that BICR stands for. We had one pathologist look at it, and this pathologist doubled that number. He said, it's not 1 out of 5. It's almost 1 out of every 2 patients that had a pathologic complete response. So how did that happen that the local hospitals were undercalling the complete response? So I went to the pathologist and I said, here's a couple of the cases where the local guys called it still viable tumor, but you said it was completely eradicated. Then he said, yeah, as I read it, they were reading some of that second column pigmented macrophages. They were reading other things as melanoma that just weren't. So that tells us there's a big teaching curve. There's still a big learning curve for our pathologists to do this really complicated math. Remember, we're asking the pathologist to basically give us these 4 categories, do math on every slide, when ultimately all they were used to doing is saying there's still melanoma here or there isn't. But we're saying that even that needs some iteration and teaching. So maybe it's not how much melanoma remains after exposure to treatment. What's the other sign of an immune response? Maybe it's a quantity of T cells coming in, not whether the tumor is dead, because that might still take time, but maybe it's T cells rushing in, or maybe it's interferon gamma, which is the hormone that activated T cells secrete. So maybe we actually should be looking for that signal of an immune response, not eradication of tumor. I hope that makes sense, that they're on different parts of the equation. So the other thing I'll mention is that the pathologist, after the tissue is exposed to preoperative treatment, hopefully that tumor is shrinking, hopefully. And that pathologist is making an estimate of where the tumor started. Because remember, the pathologist doesn't have the preoperative sample. And we don't have it. We have radiology that says that lymph node was 5 centimeters. But radiology can't tell me that that entire lymph node had melanoma, that it was 100% contained. It's a 5 centimeter lymph node that might have had 3 centimeters of melanoma, right? But nobody knows this. These are all guesses. So the pathologist, as they are reading it on the slide, are guessing based on ghost cells that they see where the boundary of that starting tumor bed was. And if you ask any reasonable pathologist, they'll tell you it's a guess. It's an estimate. That's as much as they can do. It's also an artifact, because the slide is only about 1 inch across. So you can only put about 1 inch of tumor maximum. So if you have a 5 centimeter lymph node, you're still not getting all 5 centimeters on a plastic glass slide. So this is a little bit of an artifact that's happening when we read these responses, which is again why maybe simplifying it might make it better. There's also a lot of controversy now in the pathology field on the impact of necrosis. So that's the 3rd box there. Necrosis happens in melanoma samples before any treatment even starts. So some melanoma samples just have automatic necrosis. And now there's pathologists who say necrosis is actually a bad thing. Those are the patients who are having recurrence. This is not uniformly agreed upon. Other pathologists say, oh, no, necrosis that happens after treatment, that's different than originating necrosis. So if you can separate these 2 types of necrosis, so another type of separation, then you'll be able to see who's actually having a treatment response and not. So a lot of controversy still on how to interpret these. Okay, we're getting down to the end here. Is pathologic response looking at these tissue slides? Are we ready to scale this now? Can we take this around the world? Can we take it to every hospital? I think I might have just shown you, maybe not yet. We're still having discordance on complete response rates in the tissue. So where are we going to be? We're at the intersection of what we know today and where we can go tomorrow. I think most importantly, is to recognize where we don't have any evidence, where we're essentially data free. We don't know how to answer some of these questions. I don't know what saves us from a robot uprising. Frankly, I hate these CAPTCHA codes. They have some where you could just do the audio and you can have, they'll say some word. Even that's not that much easier either, because I can hardly understand. It's usually one of these speeches that somebody's clipped out of, and then you have to type the word pathological or something. So, it's important to recognize where we're sitting in a data-free zone. I've shown you a lot of data, and the randomized trials obviously are the most robust. They have the most sort of foundational work to them. But where we're data-free, we still don't know what the best regimen is to use. We don't know if it's a single drug or combinations. More drugs leads to more side effects, but it also can lead to a stronger anti-tumor effect, probably also a stronger immune stimulation. But when you have a patient who's actually still able to have surgery, do you want to risk delaying that surgery because of side effects? Or do you, we just don't know. We really don't know. So we probably need to figure out the optimal regimen. Maybe one way to do it is to start light. And then if you get that radiology response and you don't like it, you feel like it's one of the unfavorable ones, maybe then you escalate to combination, or maybe the inverse, who knows? Dr. Hamid was alluding to this relativity 048, where we're combining all the checkpoints that we now have approved. So triple therapy, maybe that's something we use, or maybe that's a little too toxic in the preoperative setting. Let's see. It's also important when we think of these side effects, there's different types, there's different treatments for those side effects. And as soon as we start using immune suppression and steroids, we're cutting the benefit of the immune system to give you a long-term benefit. But if you get something like a rash or vitiligo, that's different, right? You may not need to use as much steroids or total body steroids. There's also this idea of light touch steroids. The duration of that side effect is really important too. Some of these are really quick to turn around, and some last weeks and weeks and weeks and can really postpone your surgery. In the preoperative and perioperative setting, neoadjuvant setting, we're using this endpoint called event-free survival. And for the purposes of this SWOG trial, we defined that as not making it to surgery. You missed your surgery because you either had too many side effects or your melanoma progressed in a way that surgery could no longer remove it all. You could progress, you just can't progress in a way where surgery can no longer be done. It's not getting to adjuvant therapy, maybe side effects, melanoma progression, et cetera. It's melanoma recurring in any form, and it's death from any cause. So this was how we defined it, but there is no uniform definition here. So Nadina actually uses a different definition of event-free survival. And it will be important that as we start looking at these trials, we probably need to agree on what our definitions are. Otherwise, we're all just sort of defining it for ourselves, and then it'll be hard to make conclusions. So what are today's clinical questions? Well, what happens if you have one of these unfavorable responses? If we can finally agree, okay, well, this actually is unfavorable, what do you do? Do you change the treatment? Do you cancel surgery? I mean, we don't know some of these answers. And what happens if you have multiple lymph nodes and they don't have the same response? One lymph node has a complete and the other has a partial. What's actually driving that patient's outcome? One camp might say it's the least responding lymph node, because that's the one that's most in danger of giving rise to new melanoma cells. But the other school of thought might be, well, that complete response tells me that immune system's already kicked off and it's the immune system doing the work. It's not the melanoma to be afraid of, it's that we want the immune system to be working. So we don't know. We've got to sort that out when you have multiple melanomas in the specimen. Can we skip surgery altogether, particularly if radiographically you can't even see that melanoma anymore? Do we still want to do surgeries? We don't know, maybe not. And then what about in that metastatic disease where it's operable? You could take out the one tumor in the lung or the liver. Does this pathology hold up, radiology, et cetera, et cetera? So just showing you those curves again, we definitely need more research on the biomarkers to help us guide. And the immediate next steps are to await this Nadina presentation at ASCO. This will be exciting. And then also, to really design smart surgery trials. And Dr. Ferries is helping to design one of these trials, looking at light surgery versus full surgery after exposure to this perioperative or preoperative therapy. We need to figure out the right regimen, the right durations, and we need better kind of science to support all of this. So that's where we are. I was extra points. I'll buy somebody a coffee out there if somebody knows where this is from. This is a pretty cool saying I just saw. I was at a meeting last week and I really like this. A woman needs a man like a fish needs a bicycle. And they actually had a fish on a bicycle, which I love a lot. So I'll thank you guys very much. And just wanted to say it's always fun to come to this meeting and see my friends here. And just in case you look at this and you think, gosh, Dr. Sullivan has a really small head. How does he fit all of that knowledge in that small head? This is a scale problem. That photo really doesn't show it. Look how tall Dr. Sullivan is. He's in front of a giant tree and he looks enormous. And even more so when he's holding his tiny little iPhone in two hands, he's dwarfing his little phone. So I'll cede the microphone to the brilliant Dr. Sullivan. Thank you.
Oh, look at that. We're on time. We will not have Dr. Sullivan come up yet. We will take a quick break after I make just 2 points. One, we just listened to adjuvant, neoadjuvant. It's not that we have solved metastatic disease, but the one point that was made on a little on the last slide is that all of this neoadjuvant work gives us something, tissue. It shows us how you respond. It gives us something, all the blood and all of the specimens on all of the information. Now, I have a patient who is a good friend who's here, and he said, this does not relate to me, but it totally does, because knowing the responses that you have with the certain features of your tumor can help us in the future biopsy someone who has metastatic disease and say, hey, look, it looks like this group of people that did well on this combination in this neoadjuvant trial, let's choose this combination. And I love it. You can always now, when you're at a meeting or talking with someone, seem like you're up to date and you know everything by saying just 2 little letters, AI. But AI in melanoma is taking all of this information, taking all of the slides and putting it in. And it's easy to say, oh, AI will do it. I don't know how it's going to happen, but it will happen. And we can craft better stuff. Those of you who know me I love to talk about the fashion industry, because it's exactly what everybody wants in everything. You want to go to a restaurant, you want to have the food that you like in that restaurant, no matter what everyone else wants. You want to go to your oncologist and you want your oncologist to say, I have crafted this for you based on your tumor and what you want and what you don't want. If I talk to my patients, they would say to me, look, I don't want any colitis. Well, we can kind of figure out who gets colitis. Look, I want a great response. How you're putting 3 things in front of me. How do you know which one works? The answer is AI and NA. Taking AI to understand the gains we've made through neoadjuvant therapy. So it's a great talk. Good stuff. We're going to take a 10-minute break, and then we're going to bring Dr. Sullivan, the much maligned Dr. Sullivan, up here. All right, 10 minutes. All right, we're going to get started again. Which if you can all take your seats, and I can learn how to use this thing. That's not it. All right. Okay, so we're back on the timer again, but actually, it's not all about what you do when you have local melanoma or what happens when you're just initially diagnosed, because our real issues now are what happens when standard initial therapies don't work optimally for you. And that's where a lot of the work that is now standard has come from. It's clinical trials, it's understanding the options, it's understanding our targeted therapies, et cetera. And there's no one better at that than Dr. Sullivan. So, Dr. Sullivan, please.
Thank you very much, Dr. Hamid. It's nice to have somebody finally say something nice about me. Right. So my task is to do exactly what Dr. Hamid said. By the way, thank you to Dr. Hamid and to the Angeles Clinic for the invitation. Thanks to Connie for all the work that she's done to arrange a smooth arrival and departure at some point. I'm going to talk about clinical trials, and I'm not going to talk about every clinical trial that's out there because we'd be here all weekend and maybe all week, but very select clinical trials. Here are my relevant disclosures. One thing I was thinking about during Dr. Patel's talk is that a synonym for disgusting would be gross, not grossing. But she mentioned the word grossing, you know, for doing stuff with samples. But why is that? It's not really a disclosure. It's really just a comment.
English is my second
language. I mean, I don't think English makes sense to anybody. Okay, so Dr. Hamid showed a version of this earlier, but this is where we are in 2024. And so when we begin to think about what are we going to do clinical trials, and it's important to see where we've come from to help understand where we're going. And so I think the summary is a lot has been done and accomplished over the last 15 years, but yet we still have a ways to go. And so when we begin again to think about what should we be studying, what patients should we be running and enrolling onto clinical trials, well, first of all, it's important to know that almost all that data, not all that data, but almost all that data to lead to all those approvals are in patients who had never been treated with the therapy for their advanced melanoma before, and almost all of them had cutaneous melanoma. And so, again, it's important to think, okay, well, where could we get better? Well, we could have better frontline therapies, and Dr. Hamid did a very nice job of describing what our frontline standard of care is and also some of the studies that are being done there. We need better second and third line therapies after CTLA-4, after PD-1, after LAG-3 inhibition. And we need better therapy for uveal, acral, and mucosal melanoma, which actually Dr. Hamid did a great job of taking us through. I'm going to tell one little story about frontline therapy. It actually is a little bit of a reinforcement of one of the things that Dr. Hamid was saying, but I think it's that important to talk about. So I'm a big Talking Heads fan. I don't know if you guys have heard of them. They're not really an LA band. You know, they're from the East Coast. They went to RISD, which is a Rhode Island School of Design, and they were hanging out in New York City for the 70s. They may or may not have become famous in the 80s. But one of their big songs was Burning Down the House. And the first line is, I'm not going to sing it for you. I'll just put it, but watch out. You might get what you're after. And when we think about immune checkpoint inhibitors, we are trying to harness the immune system for good. And I think it's a lot like fire. Like fire is what separates us from the other great apes, right? The harnessing of fire changed society, or created the opportunity for society. But if it goes awry, bad things happen. And so when we think about how can immune therapy go wrong, I tend to think of it in the setting of this slide. And so immune checkpoint inhibitors can be dangerous. Other dangerous things are patients who give you things like this. So this is a Consumer Reports, and my patient saw this, and it says, what you don't know about your doctor could hurt you. And there's a picture of a doctor with a martini glass. I don't drink martinis. But in any event, he decided to cut out a picture of my face from the internet and paste it on that. I actually have this in my office because it's amazing. But I like to use it just to say where all the problems of immune checkpoint inhibitors can happen. And so, like lots of things can happen when we give immune checkpoint inhibitors. And what I counsel my patients that any tissue in the body can get inflamed. These are really remarkable drugs that are targeting something very, very basic in our body's regulation of our immune system. IRAEs is the short version of immune-related adverse events, which is the term we use to talk about toxicity. And they can be driven by numerous potential mechanisms, but almost all of them are related to loss of tolerance. And tolerance is important because our immune system can get activated. It gets activated to go attack stuff. Usually that's cells that are infected by viruses or tumors. Tolerance keeps us from being perpetually attacked by our own immune systems. And so if you lose tolerance, you're at risk for being perpetually attacked by your immune system. And so I think the central challenge of cancer immunotherapy is to try and sort out how we can separate the things that drive the immune system to attack cancer and the things that drive the immune system in the setting of these drugs to attack normal tissue. And so the question is this: can we uncouple anti-tumor immunity from anti-patient immunity? So you saw this before. This is data from these seminal clinical trials of either nivolumab, ipilimumab, or ipilimumab, nivolumab in patients with advanced melanoma haven't been treated before. And the summary of this is that this protein, this substance called interleukin-6, can drive bad outcomes. So if you have high levels of interleukin-6, you're less likely to have a response. If you have high levels of interleukin-6, you're more likely to have your tumor grow, and you're more likely to die. And so IL-6, it turns out, is something we can target. And so one question in our minds is, can we target IL-6? The drug you heard of before, tocilizumab and sarilumab, actually block IL-6 receptor, so it's blocking the way that IL-6 signals. And so this is, one way that we can make frontline therapy better is reducing side effects. And you saw this before too. But this is, I think, going to end up being a really important clinical trial. The sort of proof of principle that you can give drugs not just to make response rates better, but to make toxicity better. The original data from this study was presented 3 years ago. This is going to be updated this year by Dr. Weber at ASCO in 3 weeks. And basically the early data, which may or may not mirror the final data, is going to suggest that there indeed is a better response rate and a lower toxicity rate than we would have expected by these two drugs, Ipi and Nivo, given at these doses. The follow-up trial, which you also heard about, is looking at 3 drugs plus a fourth, and the fourth being the IL-6 receptor blocker, sarilumab. This started about a year ago. The first part of the study is just about done. Now the randomized part comes, and the randomized part is important because ultimately, if we want to take this idea to a larger stage with hundreds of patients to really see, can we redefine the standard of care for patients by targeting toxicity? You'd probably have to have some randomized data that says, no, we did a small randomized phase 2 trial. This approach looks really good. And so the primary endpoints, again, reduce toxicity, improve responses. So that's all I'm going to talk about frontline therapy. I know Dr. Hamid talked about already, but I think it's really important that not only are we thinking about folding in drugs that might make it better to have more responses, but also we might be able to improve the risk-benefit ratio, which then ultimately can make these therapies better. All right, what else are the unmet needs? Well, again, I mentioned the second and third line therapy after standard of care immune checkpoint inhibitor therapy. We have a few different ways we can target this. We have targeted therapies targeting BRAF mutations and NRAS mutations, and we have new immune therapies, and we can cross over after those. I'm taking 2024 off from talking about BRAF targeted therapy. Spent most of 2023 talking about it. I'm just not doing it. But it doesn't mean I can't talk about NRAS targeted therapy, which ultimately it's like the same studies. So let's talk about NRAS. So BRAF and NRAS are proteins in this pathway called the MAPK pathway. MAPK is actually otherwise known as ERK, which is sort of at the bottom of that pathway. And about half of patients with melanoma have a BRAF mutation, and about a quarter of patients have an NRAS mutation, and it activates this pathway, and we actually have drugs that can block this pathway. And so this is one potential therapeutic option for patients. And basically, the strategy is just hit these proteins with big hammers, or really little hammers, so we call them small molecules, but basically big hammers. So there's emerging data with BRAF, dimer, MEK, and combinations of these in NRAS mutant melanoma. So BRAF dimer. So on this slide, ignore the man with the large hammer for just a moment, but you see the red RAF, and it's kind of signaling. There's 3 arrows going to this MEK protein. That's the BRAF that's typically mutated in melanoma. Amazingly, it just signals all by itself. Usually what RAF does is it binds with another RAF through the protein called RAS. So RAS binds to 2 RAFs and signals. And so a RAF dimer is something that blocks those 2 RAFs stuck together, as opposed to that red RAF. I don't know what color they are in people, but on the slide, bright red and brown. And so RAF dimers and MEK inhibitors have been tried in NRAS mutant melanoma. So on the left, this is one MEK inhibitor called binimetinib in data from 2 trials. That's a waterfall plot, so down is good, and you can see that most patients have down as their best response. And so that was in 2013, and people were like, wow, we might have a targeted therapy. You'd already had vemurafenib, and dabrafenib was coming out, and we're like, we're going to have binimetinib for NRAS mutant patients. Let's do a trial, and a trial was done, and that's the lower left, which is binimetinib versus dacarbazine. And it was technically a positive trial, but not positive enough for the FDA and other regulatory agencies to say, yeah, we should approve this for patients. And so it never got approved, but it clearly has some benefit in this patient population. It's just not enough. This is some work with a couple of different RAF dimers. Now, these are all solid tumor studies, but there are patients with melanoma on both the RAF dimer, the above one and the below one. And most patients who are going on this, their tumors are getting a little bit smaller. And when you start combining it with the 2 types, we're beginning to see additional responses. And so based on all of this preliminary work with these types of drugs, this trial was launched. So this is a trial of a RAF dimer inhibitor, which is designated by the blue star with the yellow stuff around it. And that's called naporafenib. So any RAF inhibitor will always have the word RAF in the middle of it. And then it's either combining with a MEK inhibitor called trametinib or an ERK inhibitor called rinaturkib. Why trametinib isn't tramekinib, I don't know. But again, words are problematic for me. Still trying to wrap my head around gross, grossing, and disgusting. So the problem when you block this pathway in two ways is you get a lot of side effects, and almost everybody got a bad rash. And it turns out you can give medications to try and prevent the rash either from happening or from being as bad. And so that's one thing that's happened as part of the study. But if you look at the bottom right and sort of furthest right are the NRAS mutant patients, there's a lot of down in those waterfall plots. And individually, there's more down than we usually see, meaning the responses, the regressions are more profound than we've seen with other things. And so based off of this data, there's now a randomized trial that's been launched that's looking at 2 doses. So the pink and the light blue doses, because those are 2 different doses of naporafenib and trametinib. So they're being studied against each other in the first part of the study. The third arm of that against each other is trametinib by itself. So we know that MEK inhibitors by themselves have some benefit. Is that me? No. Good. And so that's cool. And then once that goes forward, we're going to pick a dose. So whatever is the best dose of the combo will move forward, and that'll be decided based on responses, be decided based on toxicity, and then there'll be a physician's choice arm. And if you're really interested, you can go on chemotherapy, or you could also go on trametinib. I know what I'm going to choose. It won't be chemo. But in any event, I like this trial. We're excited to get this up and running. And it'll be the first trial of its kind testing 2 drugs in this randomized way, because if this trial works, this would be a new therapy for patients with NRAS mutant melanoma. So targeting the MAP kinase pathway is the way to go for now. Emerging data with dual pathway blockade, RAS directed. So actually, none of this is targeting RAS itself. RAS inhibitors are being developed now. And so this hasn't really been targeting NRAS to date, but we're hopeful that those types of therapies will also be developed over the next several years. And for now, the best we're going to do is this randomized trial, which we're excited about. Okay, coming down the home stretch, I have 3 minutes. I got this. No, I don't need any more. All right, so this is, now we're going to talk about injecting tumors. There is one injectable therapy approved called TVEC, or herpes light, as Dr. Patel called it earlier today. Going to use that forever. So this is a drug called mRNA-2752. It's from Moderna. It's an mRNA. It's actually 3 mRNAs wrapped up in a lipid nanoparticle that are, when they gets injected into the tumor, these proteins get expressed. And the proteins are called OX40 ligand, IL-23, and IL-36 gamma. And the idea is to improve the interaction of the immune system so that it can be more capable of attacking the tumor. There were a couple parts of this trial. Part A was looking at just the drug by itself. Part B was giving it with a PD-L1 inhibitor. On the left is one of my patients. Amazingly, in the upper left of the left, that's pretreatment. It doesn't look that bad, but he had like lots of bumps. And we started injecting these bumps, and they became dark. Because remember that picture of the melanophages from Dr. Patel's talk? So when you inject a tumor and the tumor cells explode, all these cells come by and they like basically eat up the pigment. That's actually how tattoos work. And so you can actually see tattooing of the skin from melanomas that are being destroyed. So that's what this patient had. And so on the lower left is viable tumor. On the lower right is death of tumor. And then all told, this hasn't been remarkably effective, although there is a melanoma-specific cohort that'll be presented sometime in the next year, which I think is going to look better than this slide looks. And on the lower right, it's basically just saying when you inject tumor and you look before you inject and after you inject, you see more activity of the immune system in the patients whose tumors got smaller or didn't grow versus the ones that didn't get smaller and grew. Okay, any other cool ideas? Yeah, cryoablation is cool. Literally and figuratively, you stick a probe into a tumor, you cool or freeze that tumor, and you thaw, then you freeze, and you thaw, then you freeze. I don't know how many times you freeze thaw, but several times. And it leads to interesting immune activity. We ran a trial led by Megan Meridian, one of our medical oncologists, and Florian Fintelman, one of our interventional radiologists. And we treated 17 patients who were on immune therapy. Their tumors were growing. We kept them on that immune therapy, and we just cooled or froze one of their tumors. And then when we measured benefit, we didn't measure the tumor we froze. We presumed that that was going to get smaller. So when you see 23.5% response rate, that means that those patients' tumors outside of what were frozen got smaller. So almost a quarter of patients' tumors got smaller, enough to call that patient a responder. And about half of patients had at least 6 months of durable disease control beyond when they got their tumor frozen. And again, these were patients who were progressing on the same drug we continued. So I think pretty compelling. Thankfully, Nature Communications thought it was pretty compelling too, because it just got published. So we're really excited about this. And they skipped this for time. But basically, in terms of tumor-directed therapy, lots of things you can inject into a tumor. mRNA 2752 looks interesting. Certainly some very cool things happening in tumors. Hopefully the melanoma-specific cohort looks good. With cryo, responses in about a quarter, disease control in about half. And we now have a follow-up trial in patients whose tumors have progressed on initial immunotherapy. As long as they didn't get ipilimumab before, we're giving ipilimumab, nivolumab, and we're cryoing, and we're going to see what happens. And so we've enrolled about 8 to 10 patients on that study. I think we're aiming to enroll about 30 or 40. With that, I will thank you. And you've seen some of these pictures. I'm not sure why everything was so red and pink in the lower right picture, but I refuse to have my picture taken with Dr. Patel any further because she's probably going to show it in another talk. With that, I thank you and look forward to the questions later.
See, I always learn something when Dr. Sullivan talks. I, to this date, thought cryoablation was my journeys to Boston to visit Dr. And I've learned something great. The lovely and talented Dr. Mark Ferries is up next. And I love working with Dr. Ferries because he is the epitome of the well-rounded physician. He knows radiation oncology, medical oncology, and a little bit of surgical oncology. And you can tell that he's been on all of these trials, even as an investigator on Nadina, as part of the team that brought forth herpes light, not in Europe, but in the States. And he's been involved in the adjuvant, neoadjuvant, and the metastatic space. So it will always be the greatest achievement of my career when I put a roofie in his drink and convinced him to come and work at the Angeles Clinic. So Mark, come on up here and educate us.
All right, thanks very much. Good to see everyone. I am the token surgeon in the meeting, so you can relax a little bit because the smart people taking a break from that and going on to the surgeons to talk a little bit. My task is to talk about TIL and sort of where that is and where that's going. I'm going to step back a little bit, not as far back as sort of the Neolithic surgical approach to all these things, but at least back a little bit further in immunotherapy and talk about how some of this works. So that is the mighty T cell. the T lymphocyte. And this is the critical component of most of these therapies that you've heard about. All these drugs and most of the immunotherapies that we have all eventually work through this. And so what I'll cover is, why did we even think that the immune system could be related to cancer immunotherapy and cancer treatment, and then proving that worked and bringing it to patients, and then where we're going from here in terms of modifications to the current TIL platforms and other cellular therapies. So we've known for a very long time that the immune system has some relationship with certain tumors, particularly melanoma. And so this is just a microscopic picture of a melanoma. The melanoma cells are the fat ones on the top, and all those little blue cells at the bottom are lymphocytes. And then they're not there by accident. So they have somehow recognized that something has gone wrong and have made their way to this tumor site. And we know that when we see this happening, even just in a primary melanoma in the skin, those patients are going to do better than patients who don't have this response. So the body is able to recognize melanoma as abnormal and put up some resistance. And so this relationship with in terms of immune treatments predates our even understanding of what the immune system was. And so William Coley was a surgeon in New York at the turn of the 20th century, the end of the 19th century. And he had noted, had been noted even well before that, that in patients who occasionally would get an infection in a tumor site, the tumor would go away, kind of as a consequence of the inflammation of that. And so he started to inject bacterial toxins into tumors. And reported regression in certain cases, and they know they had given enough of this treatment when the patient had a fever of 103. That's kind of how they rated the dosing. In any event, this kind of fell by the wayside after chemotherapy and radiation came along, but it still has echoes today. And so you heard about TVEC, and this is another type of intralesional immunotherapy that we used to use. Still rarely do, something called BCG. So BCG is just a TB vaccine. It's a weakened form of tuberculosis used around the world as a vaccine for TB, but we used to inject it into melanoma tumors. And so this is a woman who has hundreds of these little melanoma metastases in her leg. And you can see the little dots of blood there on the upper right. That's where tumors that have now been injected with this BCG. And she went on to develop inflammation at those sites where we injected. And we only injected probably, 10, 15% of her tumors. And then they all went away. And so what's left are just these tattoo pigment sites for this patient. And this happened not because the BCG attacked the melanoma, but because the BCG triggered this immune response, tipped the balance in her between her immune system, which was trying to fight the melanoma, and the melanoma itself in favor of the immune system. And then it was strengthened and able to go off and kill the rest of these melanoma tumors. And so that same rebalancing of the immune system is what is important with all these new therapies. So this is another one of those timelines. You've seen a number of examples of this, where for many years, decades, we had sort of nothing to offer. And then there's this explosion of new drugs, and all the ones that are in blue, and to some extent the ones that are in white, are related to the immune system and related to these lymphocytes that are the army that goes off within the body to do this. So how does this work? You can have a melanoma cell that might die, might release its antigens. Those antigens are taken up by antigen-presenting cells in the immune system that then mature, and they educate these lymphocytes, the T cells, to go off and kill more melanoma cells, and it's sort of this virtuous cycle of the immune system fighting against the tumor. It can be helped by other types of immune cells or hindered by certain regulatory components in the immune system. And so we can potentially manipulate this, and that's what some of these therapies that you may have received and certainly have heard of have to do. And so one of these ways that we've been able to manipulate this is through this interaction between the antigen presenting cell and the lymphocyte. And so these two cells get together, and the antigen presenting cell tells the lymphocyte what it's supposed to go off and attack. And there's this molecule CD28 on the lymphocyte that then is an activating signal. That cell is activated, it goes off to find the target that the antigen presenting cell has told it to go after and kill it. And then eventually it circles back around and they interact again. But this time, the T cell now has something different on its surface called CTLA4. And as opposed to the activation of the immune cell, this turns that cell off. And so one of the drugs that we have, Yervoy, it blocks that interaction. So it keeps this on, and the parking brake essentially is left off. So you've seen, the results of that and the improvements we began to see. That was the first big advance. The other type of brake is the interaction between the lymphocyte and the melanoma cell itself. So there's this interaction where the lymphocyte can recognize and then know it's supposed to kill this melanoma cell. But there can be another interaction between PD-1 and PD-L1 on the surface of these cells. And that again turns that cell off. So it blunts this ability to respond. And so the Keytruda and Opdivo, these are the drugs that act at this point. But it doesn't work for everybody. So are there ways, how can we better understand this to improve the immunity, improve the ability to have the immune system fight the melanoma? So here's that interaction between the T cell and the melanoma, the dying cell. So you interact with blocking the PD-1 there. You can block CTLA4 there. But then there are all these other components to it of different cell types that are in there. Even antibodies might be involved. And so there are various ways of targeting all those steps. And as it turns out, it's complicated, lots of ins, lots of outs. And so, totally beyond me, right? Understanding all these things. It's much simpler to think about the T cell itself. Can we just get the T cells and get those to do the job? So that's the cruise missile of the immune system. And so, again, we know that the lymphocytes can infiltrate into tumors. We can take that tumor out and we can look at it under the microscope and see those lymphocytes and highlight it with special stains and such. And then we can take that tissue that we've removed and put it into conditions in the lab that favor the growth of those lymphocytes. With lymphocyte growth factors and other things that aid those cells in proliferating. They can kill the tumor in the culture wells in the lab, and then we can take those cells out and look at them and indeed demonstrate that they can kill melanoma cells in the lab, but also expand those cells into enormous numbers through a rapid expansion protocol, just special growth conditions that really amplify those cells, and then give them back to people. And you have to give them back in a very specific context where you've created space with depleting their existing lymphocytes and then support those cells with lymphocyte growth factors afterward. But you can see that those cells that have been amplified and given back can then kill the tumors that are left in that patient. And this is not new information. So these are very old figures from papers that came from the NCI, just exhibiting responses in these patients that can happen even with fairly extensive disease and fairly rapidly. And so it wasn't a problem anymore of knowing that this could work. It was a problem of how do you actually make this happen, because it only happens at places like the National Cancer Institute or MD Anderson, these places that you can see from space, right? They're so big that it can work there, but what about the rest of the world? And so Dr. Hamid and I, foolishly enough, created our own TIL protocol and our own GMP manufacturing type facility, clean rooms and all of that to be able to do this. And we're able to do this on a handful of occasions, but it's a pretty heavy lift, right? And this is, again, not something that's going to be able to be farmed down around the world. So how does this problem get solved? It gets solved through partnerships. So, and working with industry, actually, who has the resources to be able to potentially make this a broadly available therapy. And the initial example of this was with CAR T cells, and I'll talk a little bit more about what that is in a moment. But these are cells that are, at the moment anyway, largely addressed for liquid malignancies, lymphomas, leukemias. But there are 120 companies just looking at this treatments for this one type of hematologic malignancy. There are CAR NK cells, mentioned that very briefly, and then TIL. And there are a number of companies then that have been working to make this treatment practical to be available to the population in general. The first to the table is going to be Iovance, and we'll talk a little bit about some of their data here in a moment. So this is the trial that led to now the availability of this treatment outside of clinical trials. So this is a trial, you can see Dr. Hamid's name there on the list of contributors. And so the initial report, 66 patients, and they had already failed a number of other therapies. But were able to get on to this treatment with the lymphocytes, 36% objective response rate, and the duration of response, very important, has not been reached in the initial reports. But, and this is one of the challenges with TIL, they still had to be lymphodepleted. They still had to have this interleukin-2, this lymphocyte growth factor, and that's where all of the toxicity from this treatment comes from, those components. So that still has to be part of it. It's a somewhat select group of patients that can have it. This is the waterfall plot from that trial. So waterfall plot is each of the bars on the plot represents the patient, and if their patient got smaller, the bar goes down. If the tumors got bigger, then the bar goes up. I think it was Tony Rebus that used to say we didn't have this in melanoma. We had geyser plots in melanoma. We didn't have waterfall plots, but now we have waterfall plots where the bars go down. And you can see the majority of the patients, there's some diminution of their tumor size. The other important thing about this, it's a once and done therapy, so they get treated and then they're not getting treated anymore. Even despite not continuing on therapy, the ones that have responses, those responses seem to last. And so that's enormously important for the therapies that we like to see. And so this led to the approval of this therapy with the FDA earlier this year. And there are a number of centers now that are online and coming online to be able to offer this therapy even outside of the confines of a clinical trial. So can we make it better? And so one of the problems is you can't get cells that recognize the tumors in all cases. So can you affect this T cell receptor, which is essentially the steering wheel that tells the cell what it's supposed to, where it's supposed to go? And there are ways of doing that to be able to generate these tumor-specific cells that don't require taking out tumors. And in these instances, these are these CAR T cells and also what are called transgenic T cell receptor cells. You can take lymphocytes just out of the peripheral blood and treat those outside of the body to make them specific for the tumor. And you can do this by changing their steering wheel, the T cell receptor, so that it's now specific for a tumor target. And you can also change the cells so that they have essentially an antibody on their surface. These are the chimeric antigen receptor CAR T cells that are currently available for lymphomas and leukemias. And so this can be done to sort of redirect these cells, and you make these generic lymphocytes into tumor-specific lymphocytes and then give those back. And they have different advantages and disadvantages, different strategies. So the transgenic T cell receptors recognize targets on the immune cell, on the tumor cell in the context of what's called MHC. So that's just the normal way that cells sort of put stuff on their surface to say who they are. And there are ways that the immune system can recognize those cells as abnormal, mostly because it's putting a viral protein on there or something like that. But it's good because you can have any cell, any protein in the cell can be a target inside or outside of the cell. But you have to maintain this system of antigen presentation, which some tumor cells lose. The other option, the chimeric antigen receptor, doesn't require any of that antigen presenting machinery in the cell, but it requires the target to be on the surface of the cell. It's also not restricted to certain tissue types. So some initial data from quite a while ago now on these transgenic T cell receptors showed that you could give these cells and they could persist in the patients and that they cause some decrease in the tumor. But it was all very brief, generally speaking, in these early trials and not a sustained reaction. It may have to do with the fact that what you're targeting is such a narrow spectrum of things that the tumors can kind of get out from under it. The CAR T cells are being used now, not just for these lymphomas and leukemias, but for solid tumors as well. Lots of different areas of research into various tumor types. With I'd say variable levels of success so far. In melanoma, or actually in these therapies in general, there is some concern about them because they can be toxic. And so you saw Dr. Sullivan with the fire example. These cells are alive. These therapies are alive. And so when they're given back, they can go haywire. They can sort of get out of control. And so an example where HER2, which is, you know about probably more from breast cancer, was the target in this patient. They got these cells specific for that, and the cells went crazy. And unfortunately, this patient had a horrible inflammatory response and died as a result of the treatment, not as the tumor. So some caution is still required for this. In melanoma, CAR Ts have been examined in a bunch of different trials, and we don't have a whole lot of results from these trials so far. I'd say the trials that are done already must not have been successful because we haven't really heard about them in terms of results, but lots of hope for some of these more recent trials. As they get done, we'll see what we learn from these. And this can be, the technology is such now that this can be taken really to an extreme. And so this is a schema that comes again from the NCI. The people have driven so much of this research over the years, and they'll take tumors and they'll do whole genome sequencing on them and identify all the mutations and then screen for cells that are responsive to those specific mutations, or they'll potentially generate T-cell receptors that are responsive to those mutations and give those back to the patients. And they have certainly seen with this really extensive effort, responses, clinical responses. Unfortunately, even now, they're not super common with a fairly low rate of partial responses so far anyway. But we'll see. Everyone always said that TIL was the therapy of the future and always would be. And that's come to fruition. So we'll see if the NCI brings something else as time goes on. There are lots of ways that that the TIL therapy, the current standard TIL therapy, might be modified to make it either more effective or more tolerable. You might change the timing of it. One of the issues is there's a delay between when the tissue is taken out and when the patient actually receives the therapy, and that delay can be too long for some patients. And so can you give it earlier in the neoadjuvant or adjuvant setting potentially? Can you reduce this lymphodepletion, which has some side effects? Can you make that more tolerable? Can you change the cells you pick to grow? And there are a few efforts to do that. And can you combine it with some of these other therapies that we have? Can we change the fecal microbiota to improve this? So you can see there are many ideas about how to modify these cells or modify the conditions that they're given in to make things better, even than the good results that we've seen so far. So that's the T lymphocytes. There are other immune cells that may also be useful for adoptive transfer, that is taking the cells and giving them to patients. NK cells, you heard a little bit about from Dr. Hamid. NK stands for natural killer. So that's much better than herpes light, right, as a marketing tool. But these cells have the ability to recognize certain innate things that may be present in cancer cells. They're not antigen specific, so they're not against a specific tumor antigen, but they can sometimes recognize cells based on changes that happen in cancer cells. So, for example, some cancer cells, to escape the immune system, lose this antigen presentation mechanism that you saw before from the cartoon earlier. That's a trigger for NK cells to identify them and kill them. And so you may be able to chase these tumor cells, force them down one sort of resistance pathway, and then hit them with NK cells, for example, after that. And so there are some data actually very early on. There were what were called LAC cells, lymphokine activated killer cells, treated at the NCI before they got the TIL stuff working. And about 10% of those cells were NK cells. They saw some responsiveness, but not really impressive clinical results. But some hints that there may be some clinical effectiveness of this. You can modify those NK cells, and then there's a separate type of cell called an NKT cell that also can potentially recognize sort of innate changes in the way cancer cells behave that might make them amenable to other forms of immune recognition and destruction. So the standard TIL now seems ready for prime time. It's going to be available much more broadly to patients than it has been in the past, and so that'll be a great thing. We need to figure out where that fits into the overall treatment paradigm. Right now, it is only for patients who have failed other therapies, but maybe that needs to shift around a little bit. And then there are potentially ways to modify these therapies to make them more effective over time. CAR T, I would say, for solid tumor, still many challenges to be overcome for that, but certainly an active area of investigation. And then NK and NKT cells, I think interesting. Jury's still out for now, but a lot of interesting trials that are ongoing. And so we'll see how those turn out. So, we get to be the spokesmodels for these things, right, for all these therapies. But it takes a huge number of people, and many of you have met these people. And whether it's the person that draws the blood, starts the IV, puts you through the scanner, checks off your con meds when you come in for your clinical trial visits, it requires this huge effort of all these people. And so this is who deserves a lot of credit for all these advances that you've seen. And it's an honor for us to work with these folks as well. So thanks for being here.
I'm pretty sure he could do the job of a medical oncologist. All right, that's the next hire. We'll get getting more out of the T cell, getting more out of the surgical oncologist, but it's also a big team thing here, which is important. And that is not just the medical oncologist, surgical oncologist, but utilizing our radiation oncologist cohort the best way possible. And in our collaboration with Cedars, not only do we have one, but we have two radiation oncologists who are leaders nationally and internationally in how to utilize immunotherapy and radiation, not just for melanoma, but other solid tumors. I'd like to call up Anthony Nguyen, MD, PhD, who's come to the Department of Radiation Oncology, but we steal him in medical oncology all the time, with great ideas about how not just to cryoablate, but to use radiation to ablate tumors, not just focally, but systemically. So Dr. Nguyen, please.
So I'd like to thank Dr. Hamid and Dr. Ferries for bringing us all here together with support from AIM. And I'm the token radiation oncologist, like Dr. Ferries is a token surgical oncologist. I was putting together the slide deck and really made me think about why I went to radiation oncology. And as a third-year medical student at the Dana-Farber, we saw a patient with multiply recurrent melanoma to the neck. And we really had a multidisciplinary discussion with the medical oncologist, the surgeon, and the radiation oncology team about what to do. We ended up deciding to irradiate the neck, and he remains disease-free to this date. And that's why I went to radiation oncology. But this morning, we actually had I had the same conversation with a patient in a similar position who had surgery, and he remains disease-free 10, 12 years out now. And so that really highlights the fact that there's no one-size-fits-all picture for patients with melanoma. And so this is the agenda today. The first thing, we'll just talk a little bit about the nuts and bolts of where radiation therapy fits into the management paradigm of melanoma as we know in 2024. But then more excitingly, as a person who runs a tumor immunology lab, we'll talk about the future applications about where radiation and immunotherapy may fall into the melanoma paradigm in the future and possibly in other solid tumors. And so the issue with radiation and melanoma is that it's had a fickle history. And so the foundation of radiation biology or radiation therapy actually began in a petri dish. And so back in the 1970s or 1980s, we would take tumor cells, treat them with radiation, and see how many cells live after a certain amount of radiation. And what they found in those studies is that the melanoma cells in a dish are highly radioresistant. And so that means it takes a higher amount of radiation to kill the same amount of cells compared to other tumors, such as breast cancer or even other skin cancers like squamous cell carcinomas. Such work has been done to really understand why these tumors are so radioresistant, maybe due to the intrinsic biology or the fact that it can repair DNA damage at a faster level than other tumor types. And this moniker about melanoma being radioresistant has somewhat followed its pathway here into 2024. Now, to overcome this intrinsic radioresistance, I think it leads that we need more radiation dose to be delivered to the tumor. And so that was a problem back in the 1950s, 1960s, 1970s. Here's an image of a child being treated at Stanford back in 1957. And the initial radiation therapies were quite crude. Basically, we're treated with a single field or multiple fields, exposing the vast majority of normal tissue to the radiation. But here in 2023, the way we deliver radiation has dramatically evolved to the fact that it's essentially much more precise, much more accurate, and that allows us to escalate radiation dose to the tumor. This is a patient that I treated with a tonsillar tumor in a very sensitive location in the head and neck. We were able to really deliver the right amount of dose while sparing the normal sensitive tissues. And so why is that applicable to melanoma? It's because we can now escalate our dose to the areas we want to escalate, and then preserve the normal tissue that may be limiting the amount of dose that we deliver. Again, why does this matter for melanoma? Because, again, we can really escalate or really treat the areas we want to treat. So these are examples of things like targeting brain mets, lung mets, or even in the spine, but really trying to carve the radiation off the normal tissues, and essentially becomes, as we call it, a radiosurgical procedure. Now, just to review the basic indications for where radiation fits in the melanoma paradigm, this is basically the nuts and bolts, but surgery remains the definitive therapy management for managing localized melanoma in patients who are medically inoperable or for which surgery may be medically they may be able to not undergo surgery, then radiation may be considered. For the primary site, if you have a tumor that's either desmoplastic or has extensive neurotropism, where we think that there may be high risk of recurrence, then we may consider radiation to the primary site. And then when we think about patients with nodal disease, we often consider radiation as well. In a randomized trial, it's shown that actually the adjuvant radiation to the lymph node areas can actually reduce the risk of an in-field nodal recurrences. And so we often consider radiation in patients with high-risk features, and that may include tumors that have extended beyond the capsule of the lymph node, or patients with extensive nodal burden. That means patients with more than one parotid lymph node, or multiple cervical, inguinofemoral, cervical, or lymph nodes. And then lastly, I think also the foundation of radiation oncology is in palliating patients as well. And so for patients with metastatic disease that are symptomatic or at high risk of becoming symptomatic, that we can consider radiation to those sites. And so that may be delivering radiosurgery to limited brain mets, or maybe delivering stereotactic body radiotherapy to painful spine mets or other visceral mets. And so now that we've gone through the nuts and bolts of where radiation stands in the melanoma paradigm in 2024, we can talk about a topic that actually is more interesting to me, and that's where we think the field of radiation and immunotherapy may come in the future. And so what's the rationale for combining immunotherapy and radiotherapy? Well, the fact is that the full efficacy of radiation requires an intact immune system. And so it's been shown by studies from the 1970s, and here also by Dr. Shao back in 2015, that when you deplete T cells out of an animal, the fact is that radiation doesn't work as efficaciously. And so it requires an intact immune system, and specifically the function of T cells to really carry out the tumor killing that extends beyond the intrinsic tumor killing processes of focal radiation. And so because this process is so dependent on T cells, it made sense that if you can unlock or take off the brakes off T cells with immunotherapy, this can be a natural enhancing partner. And so I like to use this slide to ask if anybody knows who that marble bust is of. I know a few of you guys know the answer to this, but this is always a real real question. Does anybody know? That's a good guess. It's not Medusa. It's something from Greek mythology. So that's Helen of Troy. So that was the face that launched 1,000 ships. And so I like to actually use that analogy because this is the study that launched 1,000 clinical trials of immunotherapy and radiotherapy. And so this was the original postdoc paper from the New England Journal in 2012, showing that combining radiation and immunotherapy could generate this abscopal response. And so by focally irradiating a single site with radiation, the combination with immunotherapy can produce a distant site in an unirradiated site, suggesting that there's this evidence of synergy between the two. And what folks often don't realize is in this trial, similar to the trial that Dr. Sullivan the more modern trial that Dr. Sullivan presented, this was a patient that was already responding to immunotherapy, but ultimately progressed. Then they received focal radiation to a lung nodule, and that led to a continued response to immunotherapy. So in essence, they were rejuvenating or reinvigorating a response that was previously there, but potentially had changed over the course of time. And they did some fantastic immune correlates showing that upon receipt of this focal radiotherapy to a lung site, you were actually generating an increase in T cell response and a decrease in immunosuppressor cells known as myeloid-derived suppressor cells. And so that was a fantastic trial. But since then, I think, like I mentioned, the trial that launched 1,000 trials, the results of combining immunotherapy and radiotherapy have been mixed. And in fact, I think much of the negative studies have been done, much of the negative trials have been done in the head and neck space. But that being said, I think you can lose the battle, but you can't lose the war. And so what we've learned from these trials is that because head and neck cancers often require a lot of radiation to the draining lymph nodes, we actually know now that potentially radiating the lymph nodes may be blunting an immune response that's generated by the combination of radiotherapy and immunotherapy. Beyond that, and that's really informed the next generation of how clinical trials are designed, combining these two treatment modalities. But the fact of the matter is that there actually have been a handful of successes where radiation and immunotherapy can generate synergy. And this has been demonstrated in multiple phase 3 trials. The first one is in the Pacific trial for locally advanced non-small cell lung cancer, where adjuvant durvalumab can actually improve outcomes in patients who receive chemoradiation. And then more recently in a phase 2 trial from MD Anderson, where after patients receive ablative radiotherapy to a lung tumor, the addition of immunotherapy actually improved outcomes in the long term. And so this is a new hope that we can potentially more logically design trials for these in the future. And in fact, suggesting that we recently actually had a workshop at the NCI where we brought together thought leaders of radiation oncology, medical oncology, surgical oncology, and industry together to really think about what are the best ways to combine immunotherapy with radiotherapy. This actually happened back in January, and we really brought up three major questions. The first one is, for the past 10 years, we've been really thinking about these two treatment modalities as working additively or synergistically. But I think with the preponderance of data in front of us, we have to really consider the fact that they actually may be even acting antagonistically, and that's something that we have to overcome. The second question really related to the tumors that we really want to look at, the targets that we want to go after, and the timing of the treatment involved. And so I'll talk a little bit about the timing later as a really important question. And the final thing is, what are the appropriate clinical endpoints for these trials? We often like to think of overall survival as the gold standard clinical trial endpoint. The fact of the matter is, in many patients with solid tumors, the progression-free survival or events-free survival is just as critically important in delaying the treatment, going down further lines of systemic therapy. And so the first lesson is that basic science is the key to advancing immunotherapy, radiotherapy combinations in melanoma and other solid cancers. And to highlight that, I think on the far left-hand side, we really think, when we think of in the far left-hand side, we just look at some how we used to characterize the immune system. And this was basically done with cell surface markers, where we try to look at how these markers can correlate with immune response. But now in 2024, we now have a wealth of new technology to really understand the immune response at a very granular single cell level. And so this is done through single cell RNA sequencing or even spatial transcriptomics, where we can look at not just the immune system as a whole, but we can actually look at the granular patterns of gene expression of individual immune cells that really tell us how things respond to immunotherapy and radiation. And one of the ways that basic science has really changed our practice, or at least here at Cedars-Sinai, was one of the studies that showed that actually that the microenvironment of liver metastases was actually potentially blunting a response to immunotherapy. And so this is work done out of the University of Michigan, but basically showing that macrophages, or the macrophages within liver metastases, were actually impairing responses to immunotherapy. And so now moving forward, we collaborate with Dr. Hamid and Dr. Faries, and we consider ablative radiotherapy to patients with liver metastases to potentially overcome these immunosuppressive signals. And in fact, similarly, building on that concept, at that NCI workshop, we had a competition for who could come up with the best clinical trial. And not to tout my own horn, but we actually came up with the top trial, which was combining liver SBRT with immunotherapy to try to really rejuvenate or reinvigorate a response to PD-1 blockade. And we won some Wisconsin cheeseheads for that prize. The second lesson is that timing is everything. And so this, of course, doesn't apply to, everything in the world, but also to immunotherapy and radiotherapy. And work that, I've done with Stephen Shao basically shows that, the immune system actually responds at a very time-dependent manner after you receive radiation. Radiation isn't just a tumor-killing event, but it also induces a de novo immune response that could potentially serve as an instigator of T-cell recruitment to the local tumor microenvironment. And so, as Dr. Hamid mentioned in his opening talk, that there are some tumors that don't have that level of T cells that are present that are required to mount an immune response to PD-1 blockade. And so we think that radiotherapy can serve as that appropriate instigator in the right context. And then again, timing is everything. And I alluded to this early in the talk, but one of the issues also is when to give the radiation with immunotherapy. And the fact of the matter is that the vast majority of trials, or at least the initial trials, have looked at concurrent immunotherapy and radiation. But if we were actually to go back to basic radiobiology principles, we actually know that T cells are quite radiosensitive. They're the first cells to die. And so by treating the lymph nodes, you actually may be ablating a response that was already there previously with immunotherapy. And so there's been fantastic work doing this, and this is a rapidly evolving space. And to this point, Dr. Shao actually ran a neoadjuvant trial of immunotherapy and SBRT, or radiation, in early stage triple negative breast cancer. And they did some immune correlates from this work. And what they found was, interestingly, that based on the baseline phenotype, or the baseline microenvironment of these tumors, we can predict which patients would have already responded already. The most favorable patients already had pre-existing anti-tumor immunity, or were able to mount a maximal immune response to this combination therapy. And so I think there needs to be more work to really understand how we actually convert the final category of patients, which were the patients with a highly suppressive microenvironment. And I think those are things that we're doing in the lab right now. And the last lesson is that we potentially need better combinations or better targets on top of immunotherapy, radiotherapy backbone. And there's been some fantastic work looking at T-cell based checkpoints, but as a person who's very interested in macrophages and innate immunity, I think there's a whole host of other immune cells, in addition to NK cells and T cells, that we haven't really fully taken advantage of. And in fact, these cells also have their own checkpoints or breaks that are limiting their activity. And we actually find that, other groups and us, we find that when we target some of these checkpoints, we can actually augment a response to radiotherapy. And in fact, in our data, we show that actually by targeting some of these innate immune cells or non-T cell based, such as neutrophils or myeloid-derived suppressor cells, we can actually unlock a level of new anti-tumor immunity and actually instigate T cell recruitment, expressing several markers of central memory that were not fully present prior to treatment. And so, in conclusion, I think we talked a little bit about the basic radioresistance of melanoma, but the fact that modern techniques can actually overcome some of these hurdles in terms of better incorporating radiation into the current melanoma paradigm. We talk about how adjuvant radiation should be considered in patients with high-risk features, but that this is obviously an ongoing conversation, a careful conversation that requires multidisciplinary input from the surgical oncologist, the medical oncologist, and the radiation oncologist. And then we talked about, again, something that's near and dear to my heart, which is how do you use radiation to potentially overcome resistance to immunotherapy and reinvigorate a response to radiation? So this was a patient from that triple negative breast cancer trial where the patient was treated with focal radiotherapy to the circle in red with immunotherapy, and then that focal treatment was actually able to produce a systemic response outside of the field. And so there's much exciting work to be done to really understand the next iterations of these targets. But with that, I'm happy to take any questions, but I'd like to acknowledge our radiation oncology department, several folks in the lab, our funding sources, and again, just a wonderful and close collaboration with Dr. Hamid, Dr. Faries, and the rest of the Angeles team. Thank you.
All right. So I like to think about this meeting as sort of like a party, like an event. We have event hosts. We have the talent. And then we have the people who really bring the spectators in. They bring everyone in, and they educate and they tell them about what's going on. And they make sure that this event is a success and that we are focused on what the people want to hear. And that is AIM at Melanoma, our 2-decade-long collaboration with Sam Guild and her family and AIM at Melanoma, and its strength is abundantly clear when the meetings become less in person and more virtual. And I'm consistently floored by how many people come in through Zoom. 150 people signed up through Zoom, and there have been over 550 Facebook interactions of people checking into this meeting. And that's the power of advocacy. It's the power of intellectualizing what needs to be done, and then telling the physicians where to focus, because we just need focus. I want to bring Sam Guild up to do the last and best part of this. And I think we're going to change it up a little. Sam's going to talk to us about what AIM is focused on now, canning beds, legislation, and all of that. And then we put together some questions about survivorship and how to go through therapy. And we were going to do it one-on-one, but maybe you can ask some of the other physicians, and I'll ask Dr. Patel to come back up to answer how they would answer these questions to their patients. So Sam, come on up.
Hi, thank you so much. So we heard earlier the number 14, and I'm going to give you another number, and that's 20. So this is our 20th year anniversary. It's an unfortunate one in some ways, because it was 20 years ago that my sister at 25 was diagnosed with stage 4 melanoma. She passed away 9 months later. But the reason why 20 is a phenomenal number is because where we were then and where we are now you would never know. And it really is to the, because of all of us in this room, those joining us online and everyone else out there, we are incredibly grateful for the community that has been built and the work that's been done since. So I don't know if I have a quick slide, but in the interest of time, I just want to quickly share with you some of the resources. If you registered or if you're on our Facebook page, you can easily find us. Oh, see, I don't do much technology. Nope, it's not there. So I'm just going to wing it. So AIM at Melanoma, we provide a number of resources. Next one, the toolkits. So side effect management sheets to support you on this, to deal with toxicity. We have a Melissa Wilson, who is a PA who can help answer your medical questions. Again, I apologize, but I want to get to some of the other things. We are addressing issues about your psychological issues that you deal with beyond the clinic, living well with melanoma, the fear of reoccurrence, skin, concerned about scans, lots of opportunities to volunteer. There's a peer-to-peer where you can support somebody going through this journey, or if you're looking for somebody to help you. We also have various up-to-date resources, and we have recently, in the last couple of years, expanded into non-melanoma. We are now providing resources for those who've been diagnosed with non-melanoma skin cancer. I apologize that the card you have in your folder is an old one because we just completely rebranded, and we are aim@skincancer.org, so that should be easy to remember. But again, it is about all of you and you working with us and together, making the next 20 years look nothing like what it does now. So I'm going to move over to the next thing because it is about survivorship and living with this disease during treatment and beyond. Tell me. Oh, perfect. Okay, so we're going to start with the very first question, and that is, how long will it take to get better and feel more like yourself? I don't know if there ever is feeling like yourself again because you have a brand new person. Which of you would like to answer this? Oh, I see Dr. Sullivan.
I'll take the first one.
Okay, why don't you go ahead?
I can review the next one. So actually, it's when you get off of a therapy, so clearly fatigue and anhedonia, which is the lack of feeling like phenomenal, are some of those things. Or if I have the rash or something from it. With immunotherapy, it does take some time to get over that. But it's also the idea that during therapy, after therapy is done, when you have control of disease, etc., it is a time to bring in others to help you feel better. We have a lovely nutritionist who helps because the diet changes, the gut changes, etc. We have, there's a lot of negative connotation to it, but it's very positive to be able to sit with someone to help you get your mind right, to be more optimistic as things are going better. And also we have social work to help. Physical therapy is a great part of it. So it takes time. It's not that when you end therapy or you have a break in therapy, you're back to your baseline. So I'll give this back to you for question 2.
So this is a question I am actually really excited about, the fact that we get to hear it all the time. The word cure is not something that's a few years ago we even discussed. But so since many people are completing treatment, can they say, I am cured? Does that word exist in our vocabulary now? So when can I say I am no longer a patient with cancer? Who would like to answer?
So I think looking at different stages of disease, especially melanoma, and cure is it has a different meaning to different people from that point of view. For early stage disease, the efforts that have been made with either pre-surgical treatment, or Dr. Patel talked at length about neoadjuvant therapy followed by adjuvant therapy, versus individuals with advanced disease, and even in that advanced disease, there are various categories. I think that answer is a little more personalized, but I think we're learning more and more that if we can get to that complete response picture and then that cure word, it's starting to come into play. I mean, how we get to that complete response with either one drug versus two versus three, clinical trials, however it is, I think we're starting to talk about it. I mean, in the past, that cure word used to be untouchable for most of the malignancies, especially for melanoma, since we didn't have much in terms of treatments. But now that we've gotten through BRAF inhibitors or Ipi-Nivo or Nivorella, I think all those are allowing us to have the courage to say that to our patient, that they may be in that territory of cure. And I think yesterday, I'm going to give an example of this. Yesterday, sitting in my office, and Dr. Hamid came over, and I told him, it's like, hey, you remember you seen one of my patients, 41 years old, disease in the bones and liver and lungs and brain. It's like she just had her first 3-month scan, or 6-month scan that shows there's no metabolically active disease. And his response wasn't, wow. It's like, great, that's what we expect. And I think that's the level of confidence we're gaining through these therapies, and hope that we can deliver that confidence to our patients and make them realize that we are getting to that point, and we hope to be there for a lot more, not just a handful of few.
Thank you. So our next question is, well, we heard a lot about the toxicity and the side effects that come with treatment. But what long-term health issues can I expect because of my cancer and its treatment? And I'm going to pass this off to Dr. Sullivan.
Thanks. One thing I definitely am an expert at is causing side effects, unfortunately. So I think long-term health issues are also individualized. Some patients go through a course of treatment, receive a year or two of immune therapy, and are wondering why they're stopping because they feel so well on treatment and it's not bothering me. I'm like, yeah, but your cancer went away. Like, there's data, we don't have to keep treating you. And if you stay on, you might not feel so well anymore. So there's certainly some patients that they probably don't have any long-term health issues. And you're probably more likely to be like that if you cruise through treatment and didn't have any side effects. There are certainly some side effects that are permanent. Most gland inflammatory side effects, thyroid, pituitary, pancreas, which leads to diabetes, tend to be lifelong, and patients need to have replacement therapy, whether that's thyroid hormone or cortisol or insulin. I think in terms of what's related to cancer, if the cancer has gone away, hopefully the symptoms related to cancer will fade over time. But if there was some catastrophic thing that happened and like there's a tumor that caused a lot of problems in the brain and there was a surgery and there were some things related to that, that may not go away. But I think the bottom line is, as patients get further and further away from the treatment, they're much more likely to recover, certainly from the side effects like colitis and lung inflammation and heart inflammation, all those things. And so I think there are some things that are very predictable. There are other things that are less predictable. Some patients still can develop side effects 6 months, a year after treatment stops, but that's rare. And I think you usually have a pretty good idea at the time where treatment is beginning to stop of what to expect. And so I think it's important to have a sit down with your provider 6 months, a year after you finish treatment and say, all right, here's where we are right now. These are the things that are happening. What can I do to maximize my health? Which sort of goes to like 5 and 6 on this list as well.
So I think Dr. Patel was ready to answer the next question. Anything you want to add?
Yeah, I feel like Dr. Sullivan answered 8 as well. So let me tackle 4, 5, 6, 7, because I got to catch a flight here. Once you finish treatment, you still have to stay in touch with your medical team. That may seem obvious, but what does that medical team look like? It's probably a combination of your primary care physician and your oncology team. You might transition to a survivorship clinic at some point after treatment. Now we're starting these survivorships 1 year after adjuvant therapy, 2 years after metastatic therapy is finished. And they can work complementary to make sure you're still doing surveillance for other age-appropriate cancers, medical conditions, secondary recurrence of your melanoma. And then I think keeping a healthy mindset as well. We focus a lot on just physical, doctor's visits and things, but making sure we keep a healthy mindset, reducing stress and keeping in a positive frame of mind. You live today and tomorrow is a gift, and you don't dwell on the past, that kind of stuff.
So I'm just going to quickly follow up the last one with, and I'm going to go a little bit off script. So we notice as a patient that we're not feeling well. What do? We know we had fatigue. We know we've had many of these side effects because of treatment. What is our next step?
Call Dr. Hamid.
Well, one of the basic tenets of my clinic, and I'm sure everyone's, is that once you leave, your visit, it's not that the visit is over. Physically, it's over, but at any time where you need to be seen or you have a change, you need to communicate. So communication is important. I think in the past, that hasn't been clear, but now, with the fact that these side effects can occur at any time, even after you've stopped therapy, it's important to reconnect. It's also important for your mindset as a patient to reconnect, because I've had patients who feel like you need the toxicity for the drug to work. It's not quite clear. It's not quite the right thing to do. Number one. Then the patients at some point have the fear of calling, that this side effect may be associated with a recurrence. And the majority of the time it's not, or growth of tumor. It's not. It's what these doctors are doing to you with their therapy that's causing it. We're the problem, so it's important. It's also the ability to feel confident that you have unloaded some of this psychological pain and anxiety onto your doctor, because we can take it and we can, squish it, make it smaller. We can carry some of that for you, and we can resolve some of that. The secondary goal is control of disease. The secondary goal is cure, and all the disease goes away. The secondary goal is to make us feel better. The primary goal in all of this is to allow you to have as normal of a life as you can have for as long as possible. And in medicine these days is not like that. You feel like people always feel like I have to go to a concierge to get better care. But I'm here to tell you, every one of these oncologists is a concierge oncologist. They're available to you all the time. They give you the best. They send you to the best. They utilize imaging and lab tests. That's a concierge doc these days, but you're getting it without the cost of a concierge. So we're always available. And the other part of it is maybe you just need to come in and be seen, because there is at a time when medicine had nothing to offer, the best thing it had to offer is comfort. The feeling that you could come and speak to someone who could decrease your fear and your pain and increase your comfort. And all of that's available at any time at your oncologist or your surgical. If I'm busy, Dr. Ferries will take you in his clinic, okay? So we all have people who work with us and are available to you.
One other thing about that, because I think part of the question is, do you, for the rest of your life, always call your oncologist for a problem, or or some of that shared by the primary care doc? And I think one of the things that we try and do at our survivorship meetings that in our clinic that's run by one of our nurse practitioners is to be clear about what's a primary care. If you get the sniffles and you're having sinus congestion, assuming you don't have sinonasal melanoma, you should see your primary care doctor for that. If you fall and hurt something, you should see your primary care doctor and they'll connect you with an orthopedist or whatever the appropriate thing is. If you're not sure what's happening to you, you can always call us. And as Dr. Hamid said, we remain your doctor forever after you're done with your treatment. And honestly, we're now getting to 10 years after Pembro and Nivo got approved. I have no idea what I'm going to do with my patients who are after 10 years. Like, we tend to graduate people. I'm not sure I'm ready to let my patients be graduated. And I'm not sure if they're ready to be graduated, they'll graduate. But if they're not ready and I'm not ready, I'll probably keep seeing them. And it's a lot easier, I think, on some level to know that that's my doctor. I see them every year and I know there's a problem. I can call them right away and they're going to get back to me. And so, I think there are clearly some things that will obviously go to the PCP. We actually relinquish control over levothyroxine as quickly as possible, even though we caused it. But I do think that there are models that are now being built to figure out how to share the care of our patients moving forward that are logical, make sense, but still allow for the comfort of having us there to take care of issues that we're not sure if it's cancer, we're not sure if it's side effects, it's probably neither of them, but come in and see me and we'll figure it out.
And I just want to say, as the patient advocate, you should be calling your doctor if you have a concern. A concern is what got you into the doctor's office to begin with, and you were right. So trust your gut. And worst case scenario, they tell you, oh no, you're healthy. You're okay. Go home. That's a good thing you want to hear. I want to apologize. I know there were lots of questions, but we are running very late and there are planes that need to be caught, myself included. It's been wonderful. We will be sending out a survey out afterwards. Please respond to it. Also, again, we apologize we didn't get to your questions. I will ask that our physician assistant, our Ask an Experts email is included on that email so that you can reach out to her and get your question answered. Again, there's no stupid question. The worst that you could hear is, you're fine. So thank you so much, everyone. Thank you for flying in, Dr. Patel, Dr. Sullivan.
Thank you.